Now, we start with the scientific program. Everything is now given to Dr. Shah to carry out the to go ahead with.
It's good to hear that I become a policeman right in the morning, that keeping the time. Without wasting much time upon Dr. Rev.
rather from hard early to 200 and then back to treat all. The treatment simplification has happened from 32 tablets of Saquinavir to just 1 tablet at bedtime. And that is also changing. We have moved to less toxic, more robust regimen with less resistance chances and definitely less toxicities. And globally, viral load monitoring is the standard, including in India and NACO program. So in 2019, WHO recommended tenofovir lamivudine dolutegravir as preferred first line for all adults, including women, and upgraded the recommendation to conditional to a strong recommendation based on the immense benefit that dolutegravir brings, despite initial reports of neural tube defects. For those who cannot take dolutegravir, the recommendation came in that use efavirenz 400 rather than 600 with equally good outcomes. We all know, just for recapitulation, there are a number of studies, including the single study which was in ART-naive patient on use of dolutegravir, comparing with efavirenz-based therapy, and Flamingo, Spring, and Sailing studies, which compared dolutegravir to other INSTIs and also their response in patients who were failing on treatment. So we all know, but just to recapitulate, dolutegravir offers a viral suppression which is much sooner, 28 days compared to 12 weeks for efavirenz 84 days. It has got very few discontinuation rate of less than 2% compared to the standard of care that was till now, that was efavirenz based regimen. Rash is also significantly less. Neuropsychiatric effects are much less, but still there are issues related to insomnia. It is a more potent regimen. Over 96 weeks of study, no known treatment resistance strains have been seen. Drug interactions are there, but they are quite minimal, and we know that it is effective against HIV too. So it offers an opportunity which can be used for all populations, all ages, and with co-infected people also. Word of caution, we all know, very important word of caution is people keep on taking a lot of drugs which are over-the-counter drugs, which contain polyvalent cations, which contain aluminum, calcium, iron. So any multivitamins, any antacids, we need to actually counsel our patient to use 2 hours before or 6 hours after DTG. And rifampicin is well known that we need to increase the dose of dolutegravir to twice a day when we are using rifampicin, because substitution with rifabutin is not really possible in terms of availability, wider availability. And other drugs like carbamazepine, amiodarone, these also have some interactions. So we need to remember, very important, patients do take drugs on their own, so that could be a big challenge with the dolutegravir. But if counseled properly, it's not a big thing. There were reports of DTG associated weight gain from different studies, advanced study, NAMCEL study, CIPAMO studies, and these were significant. Initially, these were actually welcomed by the people living with HIV, that weight gain is a good thing. But now coming with the weight gain of 6 to 8 kgs, particularly with upcoming TAF regimen, this is a cause of concern, and basically it is very important that we stress the importance of a healthy diet and regular exercise to our patients on dolutegravir. This is one component which is very difficult to follow, particularly in the ART centers with the crowds, number of patients being there. These are some of the recent CROI abstracts basically on weight gain from studies. The weight gain was seen in less than 10% of individuals who had weight gain of more than 10%. There were some risk factors like female, age, black race. These are studies from US, and switch from basically either a non-integrase inhibitor to integrase inhibitor, or from TAF, TDF to TAF. They were associated with more weight gain. Similarly, use of INSTIs was associated with 22% greater risk of diabetes compared to no risk, and a high risk of cardiovascular risk. These are small studies, but not really small, 20,000 patient, 2,000 patient, like that. There were initial concerns about neural tube defects basically when DTG was given to women of childbearing age who got pregnant while on dolutegravir. So this is an important component that NACO has been stressing, that this is not for those who come to you with pregnancy. There is no such, because neural tube closes within 28 days. But over the period, there has been updated evidence which shows that difference in the neural tube prevalence due to DTG and non-DTG regimen is much lower than previously thought. Also, there is definite evidence the benefits of DTG outweigh the risks. So definitely if women for childbearing age, we need to counsel them on the immense benefits compared to a small risk. In children also, DTG has been approved by US FDA, and also I'm aware that this has been put up for approval to DCGI also in India for children who weigh more than 3 kg of age more than 4 weeks. So in 2021, WHO came up with some updates, which were basically that WHO continues to recommend use of dolutegravir-based ART. There is a enhanced guidance on timing of ART initiation in terms of rapid initiation, including possibility of same-day initiation, use of point-of-care testing, particularly for viral load, and also monitoring of the toxicities related to dolutegravir. This is a update on the 2021 on ART monitoring. We know that WHO recommended viral load of less than 1,000 copies, but this has been updated now that if you are on a ART regimen, undetectable viral load is less than 50 copies. But if you are an efavirenz-based regimen, more than 1,000 should be immediately switched to a DTG-based regimen. But recently, the data from NACO shows that almost 90% of new patients are being initiated on DTG, and around 70% have been shifted from other regimen to DTG-based regimen, and viral load monitoring is really now being provided for all patients. That is a commendable work that has been done by NACO, because I look after other countries in Southeast Asia, and countries are still transitioning to DTG even for new patients. So current standard of care is ATLD, which we always call 1 tablet. DTG has been approved for children also. Viral load monitoring is the preferred option. But again, to reduce mortality, we need to focus on advanced HIV disease, because many patients present late to the care. These are recommendations from DHHS, IAS. There has been now a little change with bictegravir becoming, along with TAF, becoming the preferred regimen in DHHS guidelines, but still DTG, ABC, 3TC is also in the recommended first lines. So moving little away, what is focus in 2022? I'm talking more from national perspective, that there is a need to focus on advanced disease. Why? Because more than 33% of the patient present, as per NACO data, with CD4 less than 200. So still patients are coming with CD4 less than 200, and mortality is high when patients present late. So it is important that we identify patients with advanced disease. So CD4 at baseline still remains an important investigation, though it is not required for initiation of ART. Because when you say advanced disease, it is CD4 less than 200 or stage 3 or 4, which is again very difficult. So you will miss out a lot of patients if you just do clinical staging and not do the CD4. So there is a WHO package of care for person with advanced disease, screen for opportunistic infection. There is a recommendation to screen people for TB, use gene expert, use urine lamp, and screen for cryptococcal meningitis using cryptococcal antigen lateral flow assay, and then provide prophylactic therapy. Even if cryptococcal antigen is not available testing, which is the case as of now, provide a fluconazole preventive therapy for all those with CD4 less than 100. Start ART as soon as possible, and that is basically rapid initiation, what is called as starting ART within 7 days. But if the person is adequately prepared, this can be offered on the same day also. There is enough evidence in terms of benefits of early ART initiation. This is again a thing we know all, that HIV self-testing is coming up as a modality, particularly for people who are at perceived risk, and those ARVs are also being used for pre-exposure prophylaxis. Not a part of the national program, but these are being considered as pilots, and there are a lot of work going on this. So coming to new direction, what is new? What is on the horizon? How will this change the things? I'll spend the next 3-4 minutes on that. So we know that our current options are excellent, but if we have to advance, we have to do something special. What more can be done? And basically, I think some areas of research that we really need to look are using fewer drugs, perhaps a dual drug regimen which can replace a 3-drug regimen, and possibility of long-acting formulation with 1 month and 3-month injection, and a single pill also coming up, which is in the trial stage. So these are the studies, Gemini 1 and 2 and Tango studies. Gemini 1 and 2 studies showed that initial therapy with a two-drug regimen of dolutegravir lamivudine is non-inferior to DTG TDF FTC for primary endpoint, which is less than 50 copies. Similarly, Tango studies showed that switch to DTG 3DC non-inferior to continued TAF therapy. And these will all be dealt in the subsequent lecture, so I will not go into the details. Coming to long-acting ART, this is a unmet need. We know that in chronic conditions, particularly when you are well, adherence sometimes suffers despite all the counseling. So long-acting therapy offers possibility of directly observed therapy, and there are a number of options which are being studied on long-acting. But the promising one is on cabotegravir, long-acting rilpivirine, which is, there are two studies on this, Atlas study and FLARE study, and these are in the agenda again by my speakers after me. So these studies also have shown significant evidence in favor of using long-acting cabotegravir, rilpivirine from both the studies. To summarize, basically, people with viral suppression with no history of resistance to NNRTI or STIs, injectable cabotegravir, rilpivirine every 4 weeks is non-inferior to continued oral therapy. So this patient can really be switched to a monthly injection. And the studies showed that there is low incidence of serious injection site reaction, and the patient naturally satisfaction becomes very high. These are some of the things which are in pipeline, including the agent MK8591. This is a nucleoside reverse transcriptase translocation inhibitors, which is called NRTTI, and it is extremely potent. And in 2009 CROI, it was shown that when this was given at 0.25 milligram daily or 10 milligram weekly, it has an inhibitory quotient which is greater than other NNRTIs. This is another investigational agent which was again presented at CROI in 2019, a capsid inhibitor basically. The study was only phase 1 study in 32 healthy volunteers, which showed that the treatment is well tolerated, and the pharmacokinetic supported dosing every 12 weeks. This is another agent which is single oral dose of novel agent NNRTI MK8507. We know that broadly neutralizing antibodies are going to be the future, not only for HIV, for other disease areas also. And similarly, there has been a lot of talk about HIV cure, particularly the sterilizing cure rather than the functional cure. And we all must have read about this London patient, how it was different from the Berlin patient. And these are the two cases which have been cured, though these are not practical approaches as of now. But just to complete that, London patient did not receive any irradiation and basically had mild graft versus host disease compared to the Berlin patient. On vaccines, we know that vaccines are still not successful. This study was stopped after the data safety review in 2020 showed that there were 129 infections with vaccine compared to 123 with placebo. Similarly, this study was also stopped in 2021 because 51 patients, participants had active vaccine, acquired HIV compared to 63 in placebo arm. So it was not significant. And this is another study which is going on. So to summarize, what is in future, we have two prominent trends in ART guideline: fewer drugs, that is dual therapies, and long-acting formulations. And to conclude, last slide, ART is definitely a key factor in ending AIDS, but we need to focus on all big 6 components, which are awareness, early diagnosis, rapid initiation of ART, combination prevention strategies including PrEP, engage the community, and respond at political level to bring HIV back into the focus in the country. Thank you.
Thank you, Dr. Rewari, for an excellent presentation. It gives you a complete glimpse of what we have achieved and what we are yet to achieve. At the same time, just one small comment, because I'm supposed to moderate, but I won't ask many questions either. My feeling is we have achieved a lot in terms of antiretroviral therapy and its impact. Currently, for a country like ours, what is required is management of other associated illnesses, especially non-communicable diseases. I think with the treatment, people are currently comfortable, but we need to think as a nation, how do we go ahead instead of going more towards newer therapies that may come. Thank you. सर सवाल लेने का है क्या कुछ?
नहीं सर.
नहीं, ठीक.
No questions during lunch.
ठीक.
Thank you, sir. I would request all the speakers, moderators, and chairperson to collect their mementos from the preview room. Also, whoever has not given their presentation here, please give it to the preview room so that we save time. Thank you. Sir.
New various guidelines and same day rapid ART initiation. Dr. Maniar.
Main screen. I can't have big screen.
You won't have a big
screen. Yeah, sorry. Okay, it's fine. चलेगा, आता है तो ठीक है, नहीं तो जाने दो. Okay, fine. I think there is going to be lots of repetition in every presentation because Dr. Revari has made the task so simple for the subsequent presenter that he has already tried to mention what other subsequent presentations are going to say about. I just want to have a quick bird's eye view that statistics are getting updated slowly, and you still see a figure of 38 million in the world on having HIV. I'm sure it is not the correct figure, it doesn't matter. And most important point is that how many people know the HIV status, how many people are on ART treatment, how many people have virological suppression. It's all a matter of guess. India is the third largest outbreak of HIV because of the huge population that our country has. Again, we have the same problem, sexually driven, sexual transmission driven epidemic, and we have a good number of people under leadership of Dr. Revari on ART, but we still don't know the exact figure of how many people on ART, which are around 60% or so, are virologically suppressed. It's last almost more than 2 years, the virological testings are introduced. I would still feel that if somebody is on antiretroviral therapy, it's very important to do a virological load so that you know whether your drug is successfully working or a patient is adherent or no. Most important good news is that most of the pregnant women and breastfeeding women are on antiretroviral therapy so far. Maybe in the rural area, the coverage is not satisfactory, but that's okay. The TB really remains the leading cause of death even today because Dr. Revari said there are great number of people who are late presenter. And just to recapitalize, it's a multi-system disease. I think the more cases I see, the less I understand. I've crossed 1,15,000 patients. We have about 27,000 people on antiretroviral therapy. And I feel that you still need to know a lot on HIV medicine. And every day you find a changing pattern. Every day the list of the HIV indicator conditions are blowing up and up. And you can see the big list here. This is all applicable to the Indian scenario. And I would humbly request that if any one of you see this kind of condition in your practice, please do screen people for HIV. There's nothing lost. I was the first person who was very much against screening everybody for HIV, but now I feel the only way to end HIV epidemic is to test everyone, treat everyone, rather than have what is called as a counseling and consent and all things. I think it's all gone. The clear-cut benefit of antiretroviral therapy is very obvious. The pandemic is obviously going down, the morbidity and mortality going down, the incidence of opportunistic events are going down, quality of life, excellent, life expectancy, fantastic. Perinatal transmission is almost nearing zero. Sexual transmission, very important, and it's almost slowing down because of antiretroviral therapy, and of course, socio-economic improvement. what is being shown because of antiretroviral therapy implementation is 37% new infection has gone down, 66% death reduction. That's something which I feel is most achieving stuff. And I'm always comparing this with my work in leprosy. The advancement of HIV is nowhere comparable to the leprosy. And this is something which every year there's a new molecule, every year. And look at the list. It's very difficult. What I'm showing is some of the molecules are outdated, as you can see here. And every day, I have not mentioned here NRTTI, because it's still to be FDA approved, but it's something very difficult. Every year, there's a new molecule. And that's the biggest advantage of it. I've never seen, even look at tuberculosis. How many drugs over a period of 3 decades? Not much, as much as you see it in HIV. The great advancement, I would say that. And then look at the history which Dr. Rewari mentioned, where we have gone, right from the single drug to triple drug to integrase inhibitor based. Then now we're talking of 2-drug treatment, the injectable treatment, and so on. And look at the various drug delivery system that is being utilized to deliver antiretroviral drug. I think, Dr. Rewari, in a year or so time, you will see the injectables and long-acting preparation into the market, which people are desperate. But I don't think it can be generally implemented. You have to be very critical in selecting a candidate for long-acting preparation. Well, recommendation, ART, the summary is obviously whether a patient is symptomatic, asymptomatic, pregnant, breastfeeding. The moment you see this person is HIV positive, it's very important to initiate or plan for initiating antiretroviral therapy as early as we can. And I think the WHO recommendation for us looks great. The DTG, 3TC, and TDF seems good, well tolerated. All the hospitals which I go, every casualty and operation theater, we have a combination of this drug available for needle-stick injury cases. A number of people ring me about post-sexual exposure prophylaxis. I think it's a reasonably good drug with a rapid reduction in the viral load, if any. Now people are talking of double drug. So we are already in the market dolutegravir, 3TC, which can be used as a first-line therapy rather than a maintenance therapy. And there are various other combinations in market available. I was the first person who started using darunavir-ritonavir combination with dolutegravir 7 or 8 years ago when I saw a patient having a failure with the first-line drug, and it worked very well. It was 2 drugs. It was one active element was dolutegravir combined with boosted darunavir. And I think there is a lot of understanding coming up and realizing the mistake also. Same-day treatment. Dr. Rewari said about rapid therapy or early as possible. The same-day treatment is getting more and more momentum. The only word of caution which WHO says is, make sure these patients certainly have an HIV. Once you're sure about it, the same-day therapy is implementable. And I think I would still use DTG, 3TC, and tenofovir. And we'll talk about tenofovir and TF little later. But I think the thing has become very easy, single tablet, and overall well tolerated as compared to efavirenz-based therapy. I don't think that everyone who was efavirenz developed a neuropsychiatric manifestation. There are many people who have been on it for a long time and nothing is happening. And important point is switch. If you are virologically suppressed and do you want to switch to the 2-drug therapy or whatever, to simplify, idea is to have a sparing of the drug, to minimize drug-to-drug interaction, and of course the cost factor is very important. The switch is getting, I think not everybody can think of switch. In an ART center where you have a laid down guideline, I wouldn't much talk in terms of switch because suppose somebody is on a boosted darunavir and integrase inhibitor and you want to switch over to darunavir integrase inhibitor like DTG and 3TC. I think in the private practice where you have a obvious knowledge on switching and reducing the cost part, you can go ahead. Otherwise, it cannot be generalized. It has to be tailored. Yeah. And then, very small important question which Rajiv Kartik is going to touch upon. If you have a patient who is on Zidovudine, 3-TC and nevirapine for 20 years, doing very well, with 100% no side effect, do we need to change? The WHO says no. You stick to it. I have several patients on AZT, 3-TC, efavirenz, AZT, 3-TC, nevirapine, and they are really adherent, 20 years. What else you want about the adherence part? So I do not switch over to the modern drug. This is my opinion. I would like my knowledgeable participant here to share with me as and when you have an occasion here. Then come 1990 target. Not a bad idea. We had to target somewhere. Say, get a leprosy out by 2020, as late Indira Gandhi said. Same way, 1990 target looks good, though we have not 100% achieved it. Every 90% people should know their status, 90% of them on treatment, 90% virology suppressed. Unless you target, with Dr. Rewari would agree with me, you cannot reach to what you want to achieve. And you can see, it's not, except UK and other countries, where you have almost achieved full target, but average achievement was 81% knowing the status, 82% on the treatment, and only 60% are virologically suppressed. And there are various factors on that. And as I said, in India, we don't know how many people are virologically suppressed. But in my clinic, I hardly do CD4 count for a follow-up, and quite a good number. I would say nearly 95% people are virologically suppressed. I mean, all it depends on how much time you got to interact with the patient. That's very important. Unless until you keep on stressing, you cannot achieve this target. And then now they have a new target achievement plan. By 2030, they want to make sure we end epidemic. I hope we can. It's a long way to go. 95. I mean, something looks fairly good. And what is the biggest problem? In fact, I'm day by day, the more and more I'm spending my time in HIV specialty, I'm getting more and more involved into the late presentation. The biggest issue is the late presentation. Extremely important. People come with age-defining illness, and they're one of the biggest reasons to have a morbidity and mortality. And it's something, unless you have a widespread universal HIV testing, you are not going to end up this, because these are the people who transmit infection. They have bad prognosis. They have a bad high cost of management. Retention in care, very, very important. I'm sure my friend Dr. Kulkarni here will ask me that, Dr. Maniar, out of your 27,000 people, how many people are in retention of the care? Well, very good question, and I think it is the most essential component, which includes adherence even. And then, very important point, I am a promoter of condomless sex and pre-exposure prophylaxis. Undetectable equal to untransmissible. That is something, the great, I would say, among discordant couple also, if a partner is undetectable, I promote them to have unprotected sex. And this is what, as a STD doctor, I promote. And you can see almost the transmission is nil by any route. Even if you have needle stick injury, undetectable viral load, you by and large need not worry about it. And then huge number of combination for pregnancy. The ideal one, you can use DTG, 3TC, TDF, looks good. And then DTG, Dr. Rewari has already said, must. Even if you're somebody coming to you in antenatal clinic late, DTG, drug of reference, because it brings about viral suppression in 6 weeks' time. In 6 weeks' time. And it does help. Is TDF outdated? No. If your patient is tolerating, it's a good drug. If ABC outdated, no. Don't keep on talking about heart disease or cardiovascular disease incidence high with ABC. As such, in a normal population, the incidence of coronary artery disease is so high in India that I don't know why should you be changing it. And then there are drug-specific toxicity. Most important point is iris. We should know how to recognize iris. There's no testing for iris confirmation. And I think it's not uncommon at all. People taking drugs very well, viral, undetectable, still falling sick. It's nothing which is unusual. And you can see the Cmv retinitis having a paradoxical iris worsening. And on your left, you can see the leprosy, which was never ever seen, unmasked, or tuberculosis unmasked. And then HIV aging, that's the biggest problem. The more the people grow older, it's not the virological suppression which is the problem of Dr. Revare. Its problem is you're aging and you still fall sick because of comorbidities. Number of people, I can tell you, out of the huge number of people that I have now, there is no one who has got only HIV, hypertension, dyslipidemia, diabetes mellitus, thyroid problem, osteoporosis, all these renal disease, quite common. Or even because you are obese, the biggest new topic is fatty degeneration of liver. Very, very, very common if you really look for it. Look at it. On your left, HIV negative person, 80 years, and on your right, look at HIV. Look at the difference, you know. It's something, and this is what people die of. Coronary artery disease, COPD, neonate cancer. Not uncommon. This is something which you'll see more in end-stage liver disease, end-stage kidney disease. I always have in just look some or other kind of this problem seen. And frailty. Something, you're doing so well, CD4 count, everything's fine, feeling weaker and weaker and weaker and weaker. You fall. That's the frailty syndrome. This is not uncommon. You do, and age dementia. Please recognize age dementia. Cause of death before, tuberculosis. Non-tuberculosis, PCP and so on. Now, the cause of death is differing. And I just want to say in a few words that HIV number of cases living are reducing, obviously because of antiretroviral therapy. The policy is not test and wait, test and treat. And the overall mortality is 6 times higher. Even if you have everything going well, your mortality rate, because of the continuous inflammation, the 6 times higher the mortality rate, which I'm sure with everybody. And don't forget the last sentence. Earlier the diagnosis, the lesser chances are of the aging issue and holistic approach. I wish I learned this to involve your patient in your treatment planning. Thank you very much for patient listening me. Thank you.
Thank you, Dr. Maniyar. Yes, I do agree that test and treat should be our motto. And since we have safer ARVs available now, I'm sure, we can offer the best. And yes, non-communicable diseases do remain a problem, and it is time that all of us start looking into these. With this, I invite Dr. Rajiv Soman to present his case report. Dr. Soman needs no introduction. He's the father of infectious diseases in India, and I mean very well known abroad also. So I request Dr. Soman to start his case presentation.
Put it in somewhere so that I use this as a pointer.
Okay.
काही नाही प्रॉब्लेम मला हे लागतं. Hi, good morning everyone. My thanks to Dr. Maniyar. I suppose I should take the mask off now. And thanks to the chairpersons for the introductory remarks. And okay, I'll begin with this case. And I've titled it as with ART, less seems to be the new more. And in this, I'm going to discuss a case with comorbidities, previous virologic failures, opportunistic infection, and some drug-drug interactions. So take this case of a 40-year-old lady. She was HIV infected and on ART since 2005, long time ago. She had failed an NNRTI-based ART and was changed to TDF-3TC and atazanavir boosted in 2015, and this was obviously based on the EARNEST study. She was in 2017 diagnosed as a squamous cell right eye carcinoma, underwent orbital excentration, radiation, chemotherapy in 2017, and at that stage she was referred for an ID opinion. Now, her CD4 was found to be only 100 and the viral load 14,000, obviously indicating that the current ART, which was based on previous guidelines of Earnest trial, had also failed. Okay, a brief look at the Earnest trial tells you that a boosted PI plus 1 or maybe 2 and even ineffective NRTIs is going to be the treatment of choice. And this is obvious because TDF may still retain some residual activity, and both 3TC and FTC will have additional effects on the reverse transcriptase, such as increased fidelity of replication or reduced processivity of this reverse transcriptase. And therefore, a BI plus a boosted PI plus at least one NRTI, especially a benign one such as 3TC, FTC, seems to be a very reasonable thing. Then why did this patient fail? Obviously, this was based on some of the earliest follow-ups of the Earnest trial, and probably longer-term results of the Earnest study were needed. Now, there can be an explanation that there could be baseline GAG cleavage site mutations, and these might compromise the boosted PI monotherapy, especially in non-subtype B. Remind you that we have more of subtype C. So, clearly a better therapy than the Earnest trial was needed. And this comes from the two-lady study. So, if you have high virologic failure, virologic load at the time of failure, probably you need special management and not just the usual thing told to you by the Earnest trial. So, what could that be? So, one is perhaps you avoid the 800 dose of boosted darunavir. Perhaps you avoid the lopinavir ritonavir, which was the subject of study in the Earnest trial, or even its brother, the boosted atazanavir, or maybe using an INSTI instead of NRTI. And as Dr. Maniar said, he might have been the first, but I did use this combination in 2017 with all these considerations in mind. So we didn't think that Earnest trial was doing everything that we wanted for this patient. So we did use the full dose boosted darunavir with 3TC plus dolutegravir. A few weeks later, in 2017, this patient presented with features suggestive of invasive pulmonary aspergillosis. Okay, and now how do we treat this patient? Now, obviously, voriconazole has been the drug of choice for invasive pulmonary aspergillosis, but there are considerable interactions. I might not labor this too much for want of time, but remind you that ritonavir, we always think of ritonavir as an inhibitor of enzymes. But please, it induces CYP2C19, and this is the enzyme which metabolizes voriconazole. Okay, so it actually induces this and thereby hastens the metabolism of voriconazole. So it is not a inhibitor in that sense. And therefore, you need a lot of jugglery here. You need to double the dose of voriconazole and so on. So the question that came up at that time was it possible to get rid of the boosted PI in this regimen, at least temporarily, and just continue with DTG, 3TC, perhaps with an additional TDF? And was there any literature support in 2017? Yes, there was. So this was the superior efficacy of DTG plus 2 NRTIs compared with the boosted PI in second line regimen, but this is the interim data. So this is just the week 24 study, which told us that just these two, the DTG plus 2 NRTIs is expected to work. How long? At least for 24 weeks based on this interim data. And what is the duration of treatment for invasive pulmonary aspergillosis? It could range from 3 to 50 weeks. So can you get rid of the boosted PI during the time that you are going to give the patient voriconazole? That was the question. Okay, so the patient did well with the voriconazole, and it was possible to stop the treatment of pulmonary aspergillosis at the end of 8 weeks. As you can see, there has been a good resolution of this particular cavity. So now voriconazole was stopped, and then we were back to square one. Would you now add the boosted darunavir? And that's what we did. The patient was doing well. And then you had the 48-week data of the same trial of the Dawning study, which says that yes, these two drugs together, DTG plus 2 NRTIs, does perform well even at the end of 48 weeks. So that was there. So why would you want that darunavir, ritonavir? So we did stop it, and the patient just continued on DTG plus 2 NRTI. Now what does DTG owe all this potency and all these great benefits too. So it's basically the molecular architecture of the drug and its electronic properties. Okay, so it has a, I'll not go into all this. This has a high, it's a very good metals chelating scaffold, and it has a penetrator which really allows deep penetration into the integrase pocket. And for these reasons, this drug has a very high antiviral potency. It has a prolonged binding with a very long dissociated half-life. Just contrast that with the dissociated half-life of raltegravir, or for that matter, even with elvitegravir. So, not surprising that this drug will have a high efficacy even against virus which is resistant to even other entities, and will have a high genetic barrier to resistance. And these are 6 studies, and some of them Dr. Revari has already quoted. So these are all saying in chorus exactly the same thing. So if you have a patient who's got previous virologic failure, mainly with NRTI mutations in the baseline, or there are some in this where there was a failure of 3 earlier ART regimens. So obviously the patient has also been exposed to PI-based regimens. In all these, DTG 3TC fared very well, equally well as a boosted PI plus 3TC. Okay, so previous failure, not much of a concern. Previous baseline NRTI mutations, not much of a concern. Previous high viral load, not much of a concern. And in fact, the DTG based regimen, especially with TAF, would produce a lot of weight gain. Now remember, this patient was extremely emaciated with that orbital tumor and so on. So maybe DTG, all its other things which we curse it for, might be really welcome in this particular patient, like weight gain. So that brings me to the last question: is all well with this 3TC DTG? Okay, so we are in a sort of a bandwagon now to de-escalate and to use 2-drug therapy. So I just want to queer the pitch a little bit. Okay, so this is a study which looks at real life situations. Okay, so Gemini 1 and 2 told us that yes, these 2 drug regimens would be very good. But if you see the real life situation, you find now, look at this cumulative hazard of failure. And in that, with the 2-drug regimen, this curve seems to be not so good. It's not as good as the orange curve. So that's really different from RCT data, which does not show increased risk of virologic failure with the 2-drug regimen. However, in real life, 2 things happen. One is there are multiple patient-related factors as well as poor adherence. Okay, and that's a little bit different from what we see in trial data. So real life situation with 2 drugs, I don't know, may not be that good. And these are 2 very new references, and this was from January this year. So integrase inhibitor resistance mechanisms when patients have been on 2 drugs. So among the treatment experienced adults who received DTG in the Dawning study, look at the very old study which they looked at on further follow-up, they found a small number who developed these INSTI-related RAMs. Okay, and what did these RAMs do? They increased the rate of dissociation of DTG. So I was talking about DTG being very tightly bound to the integrase and remaining tightly bound for 70 hours and so on. But that did not happen when these mutations developed, and that might produce some degree of almost 10 times higher resistance to DTG. Fortunately, that also led to reduced viral replication capacity. So that tells us in nature that one thing happens, then the other thing goes in the opposite direction. And this is a study which was reported in just March, that is this month. So here we have a patient who has integrase resistance emergence on DTG 3TC with prior HIV suppression. So patients with long-term suppression and really no known risk factors for resistance can also develop some of these INSTI-related mutations. Interestingly, this patient was on clobazam. Clobazam, as you know, is an antiepileptic drug. It has a weak interaction with DTG, for which so far no dose modification has been advised. Okay, but long-term study might reveal something which is different. So really speaking, as clinicians, we need to consider carefully drug-drug interactions, even if they are thought to be clinically insignificant at present. So keep your antennas open all the time. I'll close, friends, with these thoughts. So you certainly need an appropriate diagnosis, management of opportunistic infections. So like somebody was saying that HIV is only infectious disease, and that's what my opinion is. Okay, so it is a part of many other infectious diseases. So we need to have good knowledge on how to diagnose and appropriately manage various infections, not just the opportunistic infections, but everything that a patient might have. And also pay attention to a lot of these drug-drug interactions. Watch the evolving results of trials. Like people are looking at that old trial of, say, Donning, even at the end of so many years. So there will be evolving results of trials, but even while the case is being managed. And I gave you this example because at week 24 we knew something, at week 48 we knew something. And all this can only be done with some degree of extrapolation, for which we may be forgiven, and always using some clinical judgment. The impact of current and archived resistance on the second and third line therapy is obviously declining, and the reason for that, and I told you about the potency and durability of drugs like dolutegravir. But at the end, adherence is key, cannot be de-emphasized. Even minor suboptimal adherence or insignificant, what we call today drug-drug interactions, could turn out to be significant over a long follow-up. But notwithstanding all this, less, that means 2-drug regimen, does look like the new more. So friends, every day when you are on rounds or you are in your OPD and your patient comes, just pass it through your mind. Am I giving a drug or two which is extra for this patient? Is there some scope for reduction? And I leave you with this sentence from a fashion guru, Coco Chanel: remove one accessory. So if you think that that second NRTI is an accessory, get rid of it. Thank you.
Thank you, Dr. Soman, for a nice case and the final message that you provided.
Thank you.
Can I call upon Dr. Raj Harjani? He also doesn't need any introduction because most of us are from Bombay, no?
Thank you, sir. Good morning to all. My case is intracranial NHL in HIV infected patients, a diagnostic dilemma. The past history of the patient is 42 years old male patient was detected HIV in 1997. He visited ART center in 2005, but his CD4 was good, so he was deferred ART. His chief complaints when he admitted in our hospital was a few years back. His chief complaints were fever and large painful ulcers around anus and genitalia since 3 months. Since last 3 weeks, fever was high grade with the chills and night sweats. Earlier, fever was low grade and evening rise, and there is a history of weight loss for more than 20% in 3 months. Loss of appetite, and there were no other symptoms. General examination did not reveal any lymphadenopathy anywhere. However, there was a oral candidiasis, and the local examination was about skin ulcer around the anus and scrotum. That was very large ulcer, because one photograph I am missing over here, the first one, the second one is shown first over here, and third one is the last one here. So the hyperpigmented area is such a large ulcer in the around the anus that I had never seen before. In the HIV era, I saw it for the first time. So there were a lot of differential diagnosis coming for that ulcer, and probably ulcer will be outcome of something underlying disease. So regarding ulcer, what we thought that it could be a herpetic infection, that is the most common. And what is the etiology behind such a big ulcer? Immunodeficiency, yes, but due to what? Underlying malignancy or underlying any autoimmune disorders? Same applies to pyoderma gangrenosum. It could be a result of irritable bowel syndrome, rheumatoid arthritis, leukemia, lymphoma, anything. So how to go about it? Investigated for that. And he had a HIV-1 with a low CD4 count and high viral load. We did a drug-resistant test, and drug-resistant test 4 weeks takes, and other infectious diseases were negative. We did a scraping from the ulcer to find out whether it is an ulceration of a herpes simplex, but we did not get anything. IgG, IgM were also negative. And we further investigated the patient for a biopsy. We took a biopsy to find out one of 3 diseases, what exactly we are dealing with. And we wanted to rule out malignancy, as we thought that ulcer could be a result of malignancy underlying. So there was nothing found in a chest, CT, and abdomen, and all the tests which we did were negative except from the CSF, IgG was present. So we did nothing, but we gave him a oral chemoprophylaxis and TDF FTC efavirenz since the patient was 4 years back. So this was the regime we were giving, and this biopsy started pouring in after 5 days, and it showed that it is not a herpetic infection or CME. So we just forgot that we dropped the idea of it is a herpes simplex. But we did a search on the literature, and we found out that there is an atypical perianal herpes simplex infection in HIV positive patient, and that could be the result of underlying malignancy somewhere. So we started immediately with a valacyclovir 1 gram BID for 5 days and 500 milligram BD for 7 days, and fever peaks started coming down and ulcers started healing. And the same treatment was, previous treatment was continued. However, we gave a references to the TB specialist and oncologist to find out a malignancy somewhere, because we are sure that we are dealing with a malignancy, but we are not going to pinpoint somewhere. So we did, and by the time we took a opinion of oncologist, we got this drug resistance test, and there was a primary drug resistance to NRTI and NNRTI. So we did a counseling with the patient. Here 1 month has already passed, and the CD4 never gone up from 10 to 11 or 20 or 30, but it remained at the same level. And with the counseling with the patients and patients' relatives, we changed the TDF, emtricitabine and efavirenz to lopinavir PI-based regime with a raltegravir. But suddenly we got a information that he is complaining of giddiness and loss of balance after 5 days of starting this therapy. And he had developed headache and vomiting. We made a neuro opinion, and cerebellar examination was examined, and he was advised MRI brain, plain and contrast, and screening of spine, and we found out a space occupying lesion in the cerebellum, and PET CT did not show any hypermetabolism in abdomen or thorax, but there was a single space occupying lesion. So biopsy proved that this is a diffuse large B cell lymphoma, and IHC said it's a positive expression for CD20. And we again made a review of literature, and we found out the NHL latent and not having classical presentation is a common phenomena in a seropositive patients. Also, it might be evolving at the time of presentation as his clinical signs also gradually increase. And this also says that some of the lymphomas surface after 1 to 3 months of initiation of ART. So what is a carry home message? Ulcers large or small around anus or penis are atypical presentation of HSV2 in HIV/AIDS patients and respond to acyclovir or valcyclovir, even though the Zhang smear and skin biopsy ruled out herpetic ulcer and HSV IgG and IgM were negative. If CD4 count does not increase in spite of ART in a very low CD4 count patients, think of OIs or malignancy hidden somewhere and never neglect them. And consider genotype drug resistance test for HIV-1 infected treatment naive patients to rule out transmitted drug resistance, especially if NRTI or NNRTI is used. Thank you very much. I am 2 minutes before. I gone fast.
Are there any questions from the audience since we have some time? Okay.
Thank you.
Thank you, Dr. Varli. I would invite Dr. Preeti Pillai for her case presentation on CMV in HIV infection.
At the outset, let me thank Dr. Maniar for giving me this opportunity to present here. I'll be doing a case series of CMV infection in HIV infected patients just to bring forth the various challenges that we encounter during the management of such patients. So CMV infection and HIV infected patients are often reactivation illness due to advanced immunosuppression. Spectrum of manifestation in CMV ranges from acute CMV syndrome or even an asymptomatic CMV viremia to end organ involvement. CMV reactivation may itself lead to further immunosuppression, leading to other infections like PCP, pneumonia, tuberculosis, etc. A CMV end-organ disease like CMV retinitis, esophagitis, colitis, encephalitis, myelitis result when CD4 is less than 50. And apart from anti-CMV drugs, recovery of immunity is an important aspect of treatment and recovery from the end-organ CMV infections. So let me take you through the few cases. This is a patient who is a 45-year-old female. She was admitted with pyrexia of unknown origin, and during workup, she was found to be HIV and HCV co-infected. For the workup for fever, an abdominal scan revealed abdominal lymphadenopathy along with presence of cirrhotic liver, some ascites. Biopsy proved that patient had a tuberculous lymphadenitis. She gave history that spouse had passed away 12 years ago due to a retroviral disease. Though she was diagnosed 12 years ago, during that time, she was not on any treatment till this presentation, and presently her CD4 is 65. She was started on a modified AKT based on her HCV status and cirrhosis. However, her course was complicated by hepatitis, altered sensorium, and pancytopenia. So within a week to 10 days of starting anticox therapy, she presented with these manifestations. At this stage, the initial workup considerations were whether this was an AKT-induced hepatitis or whether it's a liver decompensation in view of her underlying HCV cirrhosis, and also whether we are dealing with another TB infection in the brain. A CSF was done which showed lymphocytic pleocytosis, though there was not too much CSF proteins, and the MRI showed ventriculitis with a vasculitic infarct. At this stage, the consideration was we are possibly dealing with a tuberculous meningitis, so modified TB drugs along with steroids were continued while pancytopenia was being worked up. At this stage, even a CMV viral load was sent to rule out CMV infection. Also, a ophthalmoscopic examination was done, which revealed classical features of CMV retinitis, showing these granular cotton wool spots and intravitreal hemorrhages. A CSF gene expert was negative, AFP cultures were negative, and fundus examination was suggestive of CMV retinitis. A CMV viral load in plasma was also negative, and a CSF CMV PCR which was done revealed that it was positive. So what we were dealing with the patient with advanced HIV, CMV retinitis with HCV co-infection and a CMV ventriculitis. So this patient was treated with IV ganciclovir followed by oral valganciclovir. Her course was complicated throughout her stay in the ICU with multiple episodes of sepsis, pancytopenia, requiring frequent interruptions of therapy, and later on she was started on antiretroviral dolutegravir based along with steroids to prevent any kind of immune reconstitution. Though she recovered from the encephalitis with some sequelae, she succumbed 3 months later due to a secondary sepsis. So the learning points for me from this case was early ART can prevent multiple OIs. Managing multiple OIs in a patient with advanced HIV can be really challenging with major drug-drug interactions and complications due to drug toxicity. An occult CMV retinitis screening should be done in all advanced HIV patients so that we can pick these illness early before any further progression of the CMV disease. So this was one patient with advanced HIV, CMV retinitis along with CMV encephalitis. I'm going to the next case. This is a gentleman who was who presented with a hypoxic acute respiratory syndrome with bicyclopenia. On workup, he was found to have HIV positive, and we can see the CT scan which revealed typical features of a PCP pneumonia. So based on the radiology, we investigated for his HIV status, and he was found to have HIV positive. At presentation, he had bicyclopenia, which was attributed to the HIV status itself, and we were not able to do a bronchoscopy, but a beta-D glucan was done, which was positive, which favored a PCP pneumonia, and he responded very well to TMP-SMX along with steroids. During the workup for his bicytopenia, CMV viral load was done, which somehow, once he recovered, this report was lost. But when he came back for follow-up, we discovered that he had a CMV viremia with 5,800 copies. Now the question here is, does the CMV viremia require treatment? The patient had already responded with complete radiological resolution. So we did a detailed workup to look for any evidence of end-organ CMV disease, and there was no evidence of the same. So this CMV viremia was untreated, and on follow-up, patient showed complete resolution of pneumonia and full immune recovery after initiation of antiretroviral therapy. So CMV syndrome associated with CMV, viremia, and hematological abnormalities may be seen and may have overlap with HIV disease itself. However, and it can possibly lead to severe immunosuppression, which can also be a reason for PCP in this patient. The next, I'm going to go through a similar case. This patient again came with history of 2 to 3 months of anorexia, weight loss. He had abdominal lymphadenopathy, based on which he was put on empirical AKT. At this stage, a retroviral disease was diagnosed. However, over the next 2 to 3 weeks, he presented with acute onset breathlessness, weakness, and hypoxia. And CD4 was just 29. His X-ray showed a bilateral pneumonia. And the CT, if you can see, it was not typical of PCP. There were this interstitial pneumonitis with atypical pneumonia pattern, some dense consolidates, and even evidence of cavitation. So the possibilities here, whether we are dealing with tuberculosis, whether we are dealing with atypical mycobacterial infection, whether we are dealing with a lymphocytic interstitial pneumonia, CMV, or even Aspergillosis infection. He had a progressive course with progressive hypoxia and ARDS. He did have leukopenia, thrombocytopenia, and a low hemoglobin with mild transaminitis. Based on his clinical syndrome, and we invariably end up treating such patients with TB treatment, he was put on modified anti-cox therapy. Along with that, he was also on broad-spectrum antibiotics. His BDG was also positive, so he was also on a PCP treatment, and based on those cavities, along with that, even anti-Aspergillus treatment was started. He had a rapid progression in hypoxia in the ICU, and like just 2 days prior to getting intubated, we got a CMV viral load report of 56,000 copies, which was suggestive of a possible CMV pneumonitis. It was difficult to diagnose because apart from the viremia and the radiological picture, we don't have any other evidence. Though we started him on IV ganciclovir, he had a progressive course and he succumbed to the illness. So CMV pneumonia is often difficult to diagnose and may manifest with multiple co-infections as well. This is the last case. I don't have images of this patient. This is a lady who was known RVD, who was on first-line ART failure, and she presented with abdominal pain, loose motion, and weight loss with a CD4 of 124. A CT abdomen was suggestive of abdominal lymphadenopathy, non-necrotic, with ileocecal thickening, and radiologically reported was COX. At this stage, patient was advised to undergo colonoscopy. However, she refused to do that, and she was empirically started on anti-COX therapy, followed by optimization of antiretroviral therapy after 2 to 3 weeks. However, during that 1 month, she decided to do a colonoscopy at a different center, and she came back a month later with a report of a colonoscopy which showed CMV enteritis with typical giant cell cells and no evidence of granuloma, and gene expert was negative. So this was a lady who presented with first-line ART failure and what looked like a possible abdominal COX, which turned out to be CMV ileitis on histopathology. By this time, the patient was already better, so the empirical AKT was continued, though she was treated with 3 weeks of oral valganciclovir for the CMV colitis. She's better on follow-up and immune recovery after the second-line antiretroviral therapy. So in this case series, idea of presenting this was to bring out various manifestations of CMV diseases in HIV-infected patients. CMV disease in HIV patients are often quite rare in the post-ART era and are seen only in advanced HIV illness. When present, they are difficult to diagnose due to non-specific nature of illness, overlap with HIV-associated findings, and presence of multiple co-infections. Traditionally, CMV and organ disease are described in patients with less than CD4 less than 50, though CMV syndrome with CMV viremia, maybe even asymptomatic, may occur even with higher CD4 count. CMV itself can increase the risk of PCP and TB reactivation in HIV-infected patients, leading to co-infections. Treatment is often complicated by drug toxicities, drug interactions, and immune reconstitution syndrome. CMV pneumonia and encephalitis have poor prognosis, and treatment involves anti-CMV drugs along with immune recovery with antiretroviral therapy. Thank you.
Thank you. Thank you, Dr. Pillai. We come to the last presentation of this session, Dr. Umang Agarwal.
Okay. At the outset, I would like to thank Dr. Maniar and the entire organizing team for inviting me to present this particular case. And nice meeting you all in person after so long. So this is just one of those cases which was our last referral on a Sunday while we were just finishing off the rounds, and we received a call from the ICU saying that you have an urgent reference, please come in and have a look. So he was a 48-year-old businessman from Mumbai, known to have HIV, chronic alcoholic, chronic smoker, on a dolutegravir and atazanavir-ritonavir based regimen. And his last follow-up with us was in 2018 with a decent enough CD4 and virologically suppressed status. Now, directly after 3 years, he got admitted in our ICU with high-grade fever, along with loose motions, abdominal pain, oral ulcers, and multiple skin lesions over the past 2 weeks. He had some non-significant weight loss over the past 2 months as well. I'll just show you how the lesions look like. So this was a typical lesion that was present all across, an SCR-like lesion present all over the back, over the torso, abdomen, over the dorsum of the hands, and over the legs as well, with multiple oral ulcers. So when we went back into the history, he had history of some abdominal pain and loose motion 2 months ago, which had clinically responded to norfloxacin. He had recently been to Satara, which has a lot of farms around in that particular area. However, he said that he was predominantly limited to the urban areas. The present symptoms had commenced around a week after he had come back from Satara, and he had no recent visit out of the country. I'll tell you why that particular history is pertinent. HIV history was by and large non-contributory. An important thing was he did claim that he was 100% compliant with this treatment, and when you were speaking to the patient, you could understand that he was a relatively sensible fellow and you could believe him. On examination, he was in the ICU, drowsy, on inotropes and tachycardic, with multiple oral ulcers and skin lesions as described, and he had diffuse abdominal tenderness. I'll just go through the investigations, and the fact that the main thing that struck out was that the patient had intense cytopenias, macrocytic anemia, along with a platelet count of 1,000 and a WBC of 200. Now, even in a patient who is probably failing on ART treatment, to have a platelet count of 1,000 and a WBC count of 200 in such a case is a bit odd. When we had got the cultures done, we had a BCID to report that time, which had shown an E. coli and Klebsiella, which was quite all right. And he also had acute kidney injury. So just to summarize the case, he is a seropositive patient on a dolutegravir and atazanavir-based regimen, and with 100% adherence. Last follow-up was 3 years ago. Now seems to have come in with the neutropenic sepsis kind of a thing, with very low counts and multiple skin lesions all over. So what are the differentials that we considered at that time? TB and leishmaniasis was a bit too higher, was in the cards. However, as far as this particular thing is concerned, the skin lesions were not very typical. Moreover, leishmaniasis generally comes in more of, these particular diseases come in more in a chronic manner. This was a bit too acute. And obviously, there was no real travel history to really explain the leishmaniasis. Cmv colitis, as Dr. Pillai said, generally occurs in a CD4 count of less than 50 in a patient who claims 100% adherence. So that seemed to be a bit unlikely, but that could have explained the pancytopenia to some extent, but definitely not the skin lesions. Endemic mycosis was something that we had strongly considered given the odd skin lesions with this kind of a presentation. But then again, even in endemic mycosis, the typical skin lesions described in histo, Tyler, etc., they are more of umbilicated lesions rather than these necrotic ones. Ecthyma gangrenosum could definitely explain given that the patient had a bloodstream infection with the gram-negative infection, and so those especially Pseudomonas is most usually associated with ecthyma, but other gram-negatives are known to cause this. Rickettsia was strongly considered. However, in scrub typhus, we generally see in a single SCR. There were multiple SCRs all over. And this particular presentation is typical of African tick typhus. However, the patient had no history of traveling to Africa recently, so that seemed a bit less likely. And of course, non-infectious causes such as malignancy was one of the most common things that I was thinking of, at least at that particular point, given the very odd presentation and the dramatic cytopenias, and could have been drug-induced, but we were not really sure what it could be because of. As I said, the cytopenias was just too damn dramatic, and when I was actually writing the notes and everything, I had a flashback to a case which we had seen around 5 years ago, which basically was that of an elderly gentleman who was a resident of Northeast India, and he was admitted with cytopenias with similar skin lesions. Similar differentials had gone by our list, and when during a 3-hour history of going through all the notes and everything, we had found a small chit saying that he was prescribed a drug called folitrate, which is folic acid, but the patient had unfortunately taken methotrexate, that is Folitrax. So now I understand that methotrexate toxicity can explain the entire syndrome very well, but I don't have a history of the patient having consumed methotrexate. So then, of course, there was time to investigate. We repeatedly asked him if he had ever taken any methotrexate. He said no. We went through the entire drugs. Me and my colleague Siddharth had actually spent around half an hour to go through all the drugs to see if he was actually on methotrexate. We couldn't find any. And out of sheer desperation, ultimately, my phone was working fortunately that time. I showed him a strip of methotrexate on my phone. And he said, yes, I have taken this drug. So this was the odd thing in the sense he just saw the strip, he could recognize the strip, but he did not know what dose he had taken, for how long he had taken. And when we went deeper into the history, he said that he actually had a history of psoriasis for which he was prescribed this drug. The dosing prescribed was around 2.5 milligrams thrice weekly for some time. And he said that I was taking that drug on a regular basis. And if you actually temporally correlate, his last dose was around 2 weeks prior to his presentation, which explains the entire syndrome very well. However, of course, I still don't know what particular drug he was on, so meropenem was obviously continued for the sepsis. I'd added in posaconazole more for a prophylaxis purpose because he was quite neutropenic, and we added folinic acid to the treatment. Understandably, HIV viral load was negative, so opportunistic infections were by and large ruled out. BDG galactomannan were negative, so endemic mycosis less likely to be there. And finally, when the son came back the next day with this particular photo, that he had taken 2 such strips, 5 milligrams daily for a period of 2 weeks, which cleans the diagnosis. Now, unfortunately, since the last dose was taken around 2 weeks prior to the presentation, the methotrexate levels were negative. However, so with folinic acid, he was discharged and he was doing quite well at a 3-week follow-up. Just a small note about me. So this particular phenomena, those particular skin lesions, SCR-like lesions, they're actually called methotrexate-induced epidermal necrosis. Not very common, but definitely life-threatening. Very similar to SJS as well as toxic epidermal necrolysis. And this is how it can present. Now, an important point to note is that this is a medical emergency, and in spite of treatment, the mortality rates can be as high as 37%. Fortunately, my patient fell in the other 63%, and he was saved that time. These are the few case reports of the toxic epidermal necrolysis, methotrexate-induced necrosis that we have seen, more commonly seen in patients with psoriasis rather than any other skin condition. And yeah, that's that. So I just wanted to bring out this particular case because this was something, the diagnosis was based on something that I had seen around 4 years earlier. And eventually, if the symptoms fit in, the history did not. So you just need to keep digging in to actually get out that history. So that's that. Thank you.
Thank you very much, everyone, to abide to the timing. Thank you, Ganga Khedkar sir, for the excellent moderation, and madam for being there and introducing everyone. So before we start our second session, I would like to call upon Mr. Ravikaran Namburi, the Vice President of NATCO, who heads the Indian subcontinent business, to come here for a minute to share his views.
Thank you, Dr. Shah. Good morning, everyone. On behalf of NATCO, hearty welcome to each one of you, all the respected physicians and HIV specialists across the country. We are actually privileged to have you all together here on one platform, especially after the pandemic, where we have been restricted only on online. And this opportunity was made possible by the HIV Update team. We profoundly thank respected Dr. Maniar for giving us an opportunity, giving all of you and us also the opportunity, Dr. Mishra and Dr. Keyur Shah also. Thank you very much, Doctor. And as far as NATCO is concerned, NATCO Pharma founded around 3 decades back, based out of Hyderabad. We are completely into research and development. We have around 8 US FDA approved plants. We manufacture high quality medicines, and our chairman's vision has been very high quality medicines and at very affordable prices. As my colleague will take up further details ahead, but all these US FDA approved 8 plants we manufacture for India and for abroad also. So we are present in all regulated markets, including US and Europe. All the medicines we supply from India, that is in and around Hyderabad and across the country. So once again, welcoming you all, and once again, thanking you, the entire organizing committee, Professor Dr. Maniar, Dr. Mishra, and Dr. Shah, and entire organizing committee for giving us opportunity. Have a great time. Thank you very much, doctors. I take this opportunity to welcome Mr. Abhijit Roy, who is my General Manager for Pharma Specialty Division, to take it forward. Thank you.
Thank you, sir. Good morning to all the medical celebrities who has gathered here in this morning. I'll take you through what we are doing in the with the NATCO Pharma. So what we are doing with the global pipeline, we are shortlisting the molecule which could be excellent medication in the clinical practice, which we have started since last 15 to 17 years. And as Mr. Ravikaran has mentioned, that we are present in among all the subcontinent, whether it is Latin America, Asia Pacific, Southeast Asia, and Middle East. And our key things is that most of the 7 factories we are having, out of that for formulation 5 factories, those factories are US FDA, UK MHRA, as well as WHO approved. And our chairman is VC Nannapani, as well as vice chairman is Mr. Rajiv Nannapani. With the mission, we are serving the mankind, that making specialty medicine accessible to all. And in domestic oncology, what we have done in 2007, when sorafenib was 3 lakh rupees per month therapy, I think that's a game changer for serving the mankind, because we brought down the price to 3,000 rupees. And by that, many money as well as life was saved. Same we have repeated in gastroenterology and hepatology by bringing down the price of sofosbuvir, Sofo-Vilpa. When the international price, even domestic price was decided to launch at $600 per tablet, we brought down to 200 rupees per tablet. In fact, during second wave of the COVID, when there was acute shortage of interleukin-6 inhibitor, NATCO launched baricitinib at the price of just 30 rupees per tablet, when the international brand was 3,000 rupees per tablet. Same, we launched also Afaxiban and made it very affordable. So our commitment with the line of vision will continue in the HIV portfolio and anti-infective, a robust pipeline we have shortlisted, which we are going to unveil in the next 2 years. Now, one controversy and anti-campaign is on that whether Zapavir can be prescribed in your prescription, that is our dolutegravir. Zapavir LT is dolutegravir with lamivudine and tenofovir. And Tafnat EM is tenofovir alfenamide with amitriptyline. Now, all these molecules got the license for trade. We are part of PPP, that is Patent Pool Program, and thus you can recommend for your patient, and we are going to stay with the product. What is most important, as Sir has told, that most of our products are, we have done the bioequivalence. That means original product at affordability you are serving to the patient, which will definitely, meet your expectation to serve your healthcare. So with this, once again, I thank Dr. Maniar, Dr. Rahul Mishra, and Dr. Keyur Shah to make this event, very successful. And thank you, sir, for making us, part of this event. Thank you.
Thank you. Without wasting much time, let us start with the next session as we are running late. To start the next session, let me invite the moderator for the session, Dr. Richa Diwan, who is a senior consultant in the Department of Medicine, Sir Gangaram Hospital, New Delhi. And the chairpersons for the session would be Dr. Vibhuti Saha, who is the professor and HOD of Infectious Diseases and Advanced Microbiology School of Tropical Medicine at Kolkata, Dr. Atul Gogia, who is Professor Gripmer and Senior Consultant at Sir Gangaram, New Delhi. Please make your way to the dais. I also request all the speakers, chairpersons to collect your mementos from the preview room. Also, the speakers for the next session who have not uploaded their presentation to kindly upload their presentation. Over to you, Dr. Richa Diwan.
Thank you. As you heard since morning, everybody is talking about integrase inhibitors, and their track record has been so good that they are coming into as first-line treatment, part of combination ART, and they're also paving the way for 2-drug regimen, and as well as a long-term treatment, that means injectable. So this session is practically all revolving around these integrase inhibitors. So let's start with the first talk. I invite Dr. Neha Gupta, she's from Delhi, on integrase-based combination ART versus NNRTI-based ART versus PI-based CRT. What are the current concepts?
A very good afternoon to everybody. I think, sorry, it's good morning. So, first of all, I'm extremely thankful to Dr. Manyar as well as my mentor, Dr. Soman. And I had the opportunity to present a case of HIV on the same platform here probably a decade back, and standing here again, getting this opportunity is extremely, I'm grateful for that. So beginning with, so we are going to discuss the current concepts regarding the combined antiretroviral therapy and which is better, whether it integrates regime or the NNRTA or the PI-based regimes, which needs to be chosen. So I couldn't help but compare this with a beauty pageant, and let's see who's going to be the winner. So as we all know, for a long time, we have used the backbone of 2 NRTIs with 1 NNRTI, and in certain clinical situations, we have used PI as well, especially when it was a treatment experienced patient or in patients with HIV-2, because NNRTI cannot be used, or if there has been intolerance to the NNRTIs, or if there has been some allergy to the efavirenz or the nevirapine-based regimes. And for a long time, the integrase-based regimes were basically just evolving. But now we have definitely the new queen, and we know that the integrase-based regimes in all the various guidelines have become the preferred or the recommended regime as we can see here. So when we are considering whether we need to choose the integrase-based regimes or the NNRTI or the PI-based regime, there are certain factors which we have to consider. The first is whether the patient is a treatment naive or a treatment experienced patient. So if it is a treatment naive patient, usually we are going ahead with earlier it was NNRTI, but now it is a INSTI-based regime. And in treatment experienced patients, it is a PI-based regime because of the risk of resistance. And here, because NNRTI have a low genetic barrier to resistance, this is not preferred usually in a treatment experienced phase. Then coming to the virological efficacy and its activity against the HIV-2. So if here again the integrase-based regimes or the PI-based regimes will have activity, whereas the NNRTIs do not have activity against the HIV-2. Then we also have to look into the toxicity. So neurotoxicity to efavirenz has been one of the limiting factors in using these drugs at times. And there is some consideration even about the neurotoxicity of DTG, but it is something which is not very common. And again, the metabolic side effects are a significant problem with the integrase-based regimes. Interactions are important. We need to consider the interactions of the antiretroviral drugs with the rifampicin, with drugs used for the treatment of hepatitis C. Especially if we have an efavirenz-based regime, then it decreases the levels of velpatasvir, which is one of the important drugs for treatment of hepatitis C. And of course, interactions with the food as well as milk products is important. Then of course, the pill burden needs to be assessed as well. What is the number of pills? Of course, the boosted PI earlier would be twice daily, but now we have single pill here. And the size of the pill is also very important. The integrase-based regime, especially the DTG or the bictegravir, have a smaller pill size, and that becomes very convenient for the patients to take it as well. Coming to the allergies, usually the NNRTI-based regimes have a higher allergy incidence as compared to the boosted PI or the INSTI-based regimes. And of course, we need to also consider a few clinical situations like the pregnancy and the co-infections. And at the same time, most important, we have to look at the cost of using these drugs. So usually the efavirenz-based regimes are a little less expensive as compared to the integrase-based regimes. But again, we have to see what is the cost of not using the most effective antiretroviral therapy. Now I'll just present a couple of cases here. We have a 48-year-old gentleman who was diagnosed with HIV-1 and hepatitis B, and hep C was negative here. So the CD4 was 423 and the HIV viral load was 78,000. The BMI of this patient was 25, and in 2019, he was initiated on TAF, FTC and DTG based regime. Just in a few months, he just put on a lot of weight, close to 15 kgs, and also developed diabetes. So we have this multivariate analysis of the weight gain after starting the antiretroviral therapy, and the pooled analysis of the 8 phase 3 RCTs show that among the various groups, it is the integrase-based regimes which are associated with a significant weight gain as compared to the PI-based or the NNRTI-based regime. And if we look more deeper into it, the bictegravir-based regimes are associated with a higher weight gain as compared to the DTG, which is again high, and among the NNRTI-based regimes are associated with a much lower weight gain. Coming to the, this is another advanced study regarding the mean change in the weight by sex at 96 weeks, and here we can see that the combination of DTG TAF has been associated with a much higher weight gain both in men as well as women as compared to the TDF FTC DTG, and the least weight gain has been associated with the NNRTI based regime of efavirenz, TDF and FTC as mentioned in this particular slide. So weight gain is a significant problem with the DTG based regimes or the integrase inhibitor based regimes, which is not so much with the NNRTI based regimes. Now coming to this another case, this is a 58-year-old female who was diagnosed with HIV-1. She was also seropositive and she was taking these drugs, Methotrexate and leflunomide, and she just had a weight of 38 kgs. And she had presented with fever, which was going on for a period of 2 to 4 months. And she was then, this was the baseline creatinine of 1.4. The patient had a very high ESR. CD4 was 447 with a viral load of 52,000. And HLA-B5701 was negative. And this was the CT scan, which showed a few centrilobular nodules present in the lungs. So this was a case of HIV-1 with tuberculosis. And she was started on rifampicin-based anti-TB drugs. Now 4 weeks later, she was initiated on abacavir, 3TC and DTG. And here we had used double dose DTG because of the interaction of rifampicin with the DTG. However, she presented with diarrhea, myalgia and nausea. And the, after ruling out all the opportunistic infections, as we just heard Dr. Umang mentioning that the side effects of the drugs also need to be considered. This was, after ruling out all the other possibilities, this was attributed to the drugs. And here, when we looked at it, the DTT-based regimes can also present with the GI disorders as well as with arthralgia, myalgia. And so this was the possible, this patient was not tolerating this particular regimen. So in this patient, alternative backbone was being considered. So can we use raltegravir or should we use PI-based regime or a efavirenz-based regime? So coming to raltegravir, again, it belongs to the same class, may have similar non-tolerability. What about the PI? Rifampicin has significant interaction with the PI, and rifabutin anyways was not available and is more expensive also, particularly in the Delhi NCR. And the other alternative which can be used is a efavirenz-based regime, and whether we need to use a 600 or a 400 was the other consideration. So this is basically the table which shows the interaction of the rifampicin with the NNRTI as well as the PI-based regimes as well as with the integrase-based regimes. And rifampicin significantly reduces the levels of the PI as well as of the integrase inhibitors. However, we can still use the INSTI-based regimes in double dose as we did in our patient. But with the PIs, they cannot be used. Either we need to change rifampicin to rifabutin, but this is not really available. There is also a slight decrease in the AUC of efavirenz, but it is clinically not significant, and we can use this particular regime with the rifampicin. Now, between 400 and 600, so we have the trial, ENCORE trial, which compares the efavirenz 600 with efavirenz 400 with this, and we can see here that the efavirenz 400 and the efavirenz 600 was found to have a similar virological suppression at the end of 48 weeks. And even the CD4 mean change was found to be similar, and the efavirenz 400 was found to be non-inferior to the efavirenz 600. Now coming to another trial, which is the NAMCEL trial, which compared the TLE 400 versus TLD, and as we can see here in this, the viral load suppression was of the TLE 400 was similar to the TLD at the end of 48 weeks. Coming to the interaction of TLE 400 with the rifampicin, the levels are not really significantly lower as such with the TLE 400 and rifampicin. And coming to the adverse events associated with the TLE 400 and 600, efavirenz 400 is significantly associated with lower side effects as compared to the efavirenz 600. So these are the couple of interactions which we have to, so in this particular patient, we had started off her on TLE 400 and she's tolerated that particular medication as well as she is virologically suppressed as well. The other considerations when we are choosing the combined, choosing the antiretroviral therapy are of course interactions, and I've just mentioned regarding the interaction of HIV antiretroviral therapy with the HCV. And if a patient is taking HIV HCV co-infection is on velpatasvir, then efavirenz cannot be used. Coming to the various other drug interactions, as we can see here, so efavirenz-based regimes or even the boosted darunavir-based regimes, they do not have any potential interaction or no interaction is seen with the antacids or with the multivitamins. But the DTG-based regimes have to be avoided with milk and milk products and probably even along with the antacids. And this is a particular table which briefly compares the various factors which we need to consider before choosing the antiretroviral therapy. So efavirenz-based regimes again have a low genetic barrier to resistance, but the DTG-based regimes have a high genetic barrier to resistance, so that becomes important. And when we have a PI-based regime, it's basically that needs to be used in a patient who is treatment experienced and not really a treatment naive patient in the current scenario. Again, activity against the HIV-2, NNRTIs have only HIV-1 activity against HIV-1, whereas both HIV-1 and 2 will be covered with the PI-based as well as with the integrase inhibitor-based regimes. We need to look into the side effects. Efavirenz is associated with significant neurotoxicity, and sometimes in a patient who is having neuropsychiatric manifestations or is having some bipolar disorder, then he may not tolerate it even more. And these patients who have a bipolar disorder, they may also be on antipsychotic medications which may have interaction with the PI. And as Dr. Soman mentioned, drug-to-drug interactions are very important to be considered in our clinical practice. DTG-based regime have a significant problem with the weight gain. Usually, the neurotoxicity associated with the DTG or with the raltegravir is less, it's just 2 to 3% only, and in most cases the patients tolerate them well. PI-based regimes have a significant toxicity associated with the cardiovascular toxicity, GI intolerance, dyslipidemia, and these need to be considered. If a patient is likely to have more cardiovascular risk factors, then of course, based on the DAT study, PI-based regimes should be avoided. Drug-drug interactions I have just mentioned again. Coming to pregnancy, we can use a DTG-based study, DTG-based regime based on the recent Botswana study. However, for the bictegravir, we do not have any such data regarding this. PI-based regimes can also be used. Coming to the pill burden, it's a single pill with the DTG. The smaller size is even smaller with the bictegravir-based regimes, but PI-based regimes are a larger pill and much more difficult to take. And coming to even the timing of it, so with the efavirenz-based regimes, one has to take it during the night only, whereas the DTG-based regimes can be taken any time during the day, but it's important to just avoid them with milk and milk products, which should be avoided 6 hours before and 2 hours later. So these are the few considerations and few clinical situations which can help us in deciding which antiretroviral therapy to actually choose. And there are few drugs among the NNRTIs which are definitely on the pipeline, and this is one drug which is doravirine, and this is approved as such in certain clinical situations as well. The importance of this NNRTI is that it can be used even if there is significant NNRTI mutations like the K103N, Y181C and G190A, and it has a much favorable drug interaction profile as well. So probably it's a wishful thinking that we will have definitely better drugs as well available in the near future. And the key take-home points would be that first-line regimes recommended by the current guidelines for most people living with HIV are the integrase inhibitor-based regimes, but they are associated with a greater weight gain. And if there is intolerance, as in my second case, the patient could not tolerate the DTG-based regime, then of course in these situations, NNRTI-based regimes need to be preferred. And NNRTI-based regime is definitely an option for patients who have adverse events like the weight gain or intolerance. And while we are choosing these drugs, it's important to clinically evaluate the labs, prior regime, as well as all the other dietary factors have to be also considered before starting the NNRTI-based regimes. Thank you so much.
Thank you for finishing it on time. I think she's made this very clear that integrase inhibitor-based treatment is the choice right now, but still, as Dr. Manyar also said, that those who are following or who are doing well on the earlier combination treatment, they can continue. But one of the issues that you brought out very well about efavirenz was that if they're having neurotoxicity, for which they were saying, okay, use integrase-based integrase inhibitors, reducing the dose of efavirenz also takes care of these neurotoxicities.
Yeah.
Thank you, Neha. Thank you very much.
Thank you, Dr. Richa. Thank you.
So now we move on to the next speaker, Dr. Rajiv Kartik from Vellore. In fact, we have been hearing about the options which are available for the drugs and the newer drugs which are in the pipeline. So, and also we have been hearing about use of 2-drug ARTs. So it's now with Dr. Rajiv Kartik to tell us about this. Over to you.
Good morning, everyone. At the outset, I want to thank Dr. Manyar and the organizers of this event for giving me an opportunity to speak here. Just as Neha said, it was almost a decade ago that I last attended this meeting, and I had presented at that time as well. So we've heard a lot today about ARTs and INSTs and how good they are. And forgive me if you will hear it again, but what I'm going to take you through over the next 15 minutes or so is what are some of the evolving treatment strategies that we have, and what does the future look like. So I'm going to look at evolving options for first-line ART. What are some of the switch strategies that we can use? We've heard briefly about 2-drug ART. How can we use them? Who should we use them in? And why should we consider it? And should we actually change a successful ART regimen or not? So these are the things I'm going to be actually going through. So now we are in the age of test and treat. This is not the same a few years ago. We have goals. The 90 goal, as Dr. Manyar had talked about, this has been revised to 95, 95, 95. So we have to do something to achieve these goals. And what is going to help is an integrated approach, yes, but also some of the newer drugs that we have and how best that we use them. So when we look for a drug, which is going to be used on a lifelong basis, these are some of the characteristics that we would want. We would want it to be tolerable, of course efficacious, and this efficacy should be shown in clinical trials. Toxicity should be low. Good pharmacokinetics that allow a very, very good dosing pattern, and we know that most of the drugs now enable this. High genetic barrier of resistance, meaning that several mutations are needed before the drug becomes resistant, and of course low cost and global access. Some of the earlier drugs that we've had in the past, like the previous NRTIs, tavudine, didanosine, all of them were very toxic. They had very, very poor genetic barrier to resistance. So we had a lot of trouble with the earlier pills, but this is something that we would need going forwards. And what actually came out of these integrase inhibitors, we knew about raltegravir and elvitegravir from 2004, but they were not as exciting as the subsequent instis, especially dolutegravir, which came out in 2013, and more recently bictegravir. And of most interest now to everybody is the injectable long-acting integrase inhibitor with this cabotegravir. Other drugs that have come into the pipeline are TAF, tenofovir alafenamide. It's just a different form of tenofovir. We still have boosted PIs, of which darunavir is the most preferred. And we have low-dose efavirenz. I don't want to sort of discount efavirenz as a poor drug. It has come into a little bit of disrepute because of some neuropsychiatric toxicity, but by no means is it a bad drug. We all have lots of patients on efavirenz who do very well, and Dr. Neha has really touched upon the lower dose efavirenz, how it still works. So this is what is currently in our armamentarium. I know this is an old study, this is a single study, but this was the study that changed the way we look at ART. This looked at the then current regimen of TLE versus a dolutegravir-based regimen, and you can see clearly both viral suppression and CD4 response was far better when dolutegravir was used. What was the concern with efavirenz? Efavirenz was not a bad drug per se, but the concern was this. The concern was the neuropsychiatric toxicity. And when you use dolutegravir, I'm not saying dolutegravir doesn't have neuropsychiatric toxicity, it does, but it's much less. It's only about 2%, whereas it's about 20% with efavirenz. So toxicity was much less. Yes, with dolutegravir, there is some increase in creatinine, but this is not associated with a reduced GFR. This is just because there's a decreased secretion of creatinine that happens with dolutegravir, and there's no reduced renal function. Looking at the same study, this was used across all populations, whether you used it with a high viral load, low viral load, CD4 count low, CD4 count high, women, men, age group, it didn't really matter, non-white, white. This drug worked across all subpopulations. So this is really a drug that was checking off all the boxes that we wanted as an ideal drug. Then, we've talked about all these studies. Dolutegravir was compared with every other drug that was there. So, against efavirenz, against boosted PIs, against other instis, in different situations, treatment experienced, treatment, naive, and it really showed that its efficacy was comparable or superior to all these agents. Other advantages of instis, they're very well tolerated. Ease of administration is a daily pill, single daily pill. Fewer drug-drug interactions. When we say fewer, it doesn't mean there are none. And as Dr. Soman pointed out, there may be drug interactions that we don't know of yet, and it may be relevant. So we should always watch for drug-drug interactions. Don't discount it just because it's an insti. There may be drug-drug interactions, and we need to look carefully in each of our patients. And a high genetic barrier to resistance. We know that, lesser adherence to this drug really doesn't lead to the emergence of mutations. A couple of years down the line, we had some more good news. Bictegravir came out, and when this was compared head-to-head, and bictegravir comes out only co-formulated with TAF and FTC, and this was compared to the then standard of ABC3TC and dolutegravir, and it did equally well. So we had two instis, dolutegravir and bictegravir. And this slide, I think you've seen in every single presentation till now. These are the recommendations from the DHHS and the IAS, where insti-based regimens are what are recommended. So bictegravir, FTC, TAF, ABC3TC, DTG, or DTG with FTC or TAF. So this is what is sort of recommended. This little point here, I'm going to talk about in detail in the next few slides as a 2-drug regimen. This is the WHO guidelines, and very similar, where they use an INSTI as the drug of choice. But what I want to point out is, don't discount efavirenz. Efavirenz is still a good drug. It does have some neuropsychiatric toxicity, but about 80% of the patients actually tolerate it well. So let's not discount it. And efavirenz at a lower dose, especially for a resource-limited setting like ours, can definitely be used. May not be in the first line, but at least as an alternate agent. So it does have good viral suppression. It can be used with rifampicin, and it has equal viral suppression compared to TLD, as we saw in the ENCORE study. So just a point I want to make about the dolutegravir in pregnancy. I think there was some concern about the increase in neural tube defects, and people were hesitant to use it in women who were going to conceive. But then subsequent data from the same study actually showed that the neural tube defects are actually much less, and dolutegravir is actually recommended for use in women who are likely to conceive. So the initial numbers were higher, and there was a concern, but then this CEPAMO study, subsequent data has shown that the risk of neural tube defects is not different from women taking other drugs. So I'm going to talk a little bit about some of the evolving strategies. And the first one I'm going to talk about is, what about dual therapy at the initiation? So why did people start thinking about dual therapy? One is the concern about long-term toxicities of drugs, which people have been taking for many, many years, 10, 15 years, and what that would do in terms of cumulative exposure to these drugs and toxicity. The second, of course, was the arrival of dolutegravir and the second generation INSTIs, which were very efficacious, they were safe, and they were easy to tolerate. And of course, concerns with drug interactions, pill burdens, cost, all these three factors almost at the same time sort of led to people starting to think about two-drug therapy. And this was the first study that sort of looked at two-drug therapy. It's a Gemini 1 and 2 study, which compared dolutegravir and lamivudine versus tenofovir, emtricitabine, and dolutegravir. So basically, this study was a randomized double-blind study. Adults, ART naive, HIV RNA between 1,000 and 5 lakh copies, no hepatitis B infection, and no major resistant mutations. So they were randomized either to get the standard of care, which was TDF, FTC, and DTG, or they got DTG and 3TC. And primarily, they looked at viral suppression and the emergence of resistance. So if you look and see over time, you can see that up to week 144, the efficacy was almost the same. It was 82% in the two-drug group and 84% in the 3-drug group. And this fell within the range of limit of non-inferiority. So this study actually showed us that following up patients for at least 144 weeks, a 2-drug regimen of dolutegravir and lamivudine seemed to be as good as a 3-drug regimen at that point in time. So in whom should we consider? What I want to impress here is that there's no need to change a regimen just because it's the newest thing that has come out in the market. So these are some of the prerequisites, and we should be careful about this. We wouldn't want to start it if the baseline HIV viral load is more than 5 lakh copies, because definitely there was a poorer performance and the emergence of resistance. Similar to this, probably a CD4 count of less than 200, you wouldn't want to start. So somebody who has very advanced disease, CD4 of less than 200, or a viral load of more than 5 lakhs, you wouldn't want to consider 2-drug regimen. You don't want to start it if there's hepatitis B infection, and we really need to know a baseline resistance test to know if there are any mutations for NNRTIs or INSTIs. So that may not be something that we all do in every patient, but we really need to know that there are no mutations. We're using only 2 drugs, and we need to know that these 2 drugs are going to work. So these are the prerequisites for considering somebody for a 2-drug regimen. Many of the times, it may be forced upon us that we cannot use certain drugs, chronic kidney disease, HLA-B5701 being positive, severe anemia because of chronic kidney disease. all your other drugs are rendered, are toxic, so you can't really use them. So in such a situation, you may be forced to, choose a 2-drug regimen at the get-go, but ensure that these prerequisites are fulfilled before even considering the 2-drug regimen. So the next question is, in patients who are virologically suppressed with 3 drugs, what are the options that we have for a 2-drug oral therapy? And this came out through many studies. The most important of those, which I think is the SWORD 1 and 2 studies, where they looked at individuals who are more than 18 years, who are on stable ART for more than 6 months with any regimen, and they had a virally suppressed HIV RNA, hepatitis B negative. They were randomized to either continue their regimen, or they were given dolutegravir and rilpivirine 25 milligrams. And at the end of 48 weeks, all of them were switched to this dolutegravir and rilpivirine. And you can see here, this is week 48 data, but even the subsequent data shows that the viral suppression is very, very similar in both the groups. So several more studies went on to show this. The TANGO study looked at similar population of patients who were virally suppressed and who didn't have hepatitis B and were on a stable regimen, who were switched to dolutegravir, lamivudine, and the results were similar. The SALSA study actually showed patients who were on a 3-drug regimen for more than 3 months, who were switched to, again, dolutegravir and lamivudine and continued their current regimen, and the outcomes were very similar. So you can see that 93% and 94% were virally suppressed at the end, at week 48. What about other drugs? We're only talking about dolutegravir and lamivudine. Can we use some other drugs? And this looked at patients who are already on PI-based therapy. They were continued with dolutegravir and boosted darunavir, and this was continued. And again, the viral suppression was good. So several studies have shown that patients who are virally suppressed with their current regimen can be managed with a variety of combination of ARTs without any adverse outcomes. So coming to the future, what do we expect? There's a lot of now new information about the injectable long-acting cabotegravir, which is an INSTI. And I'm not going to discuss the ATLAS and the FLAIR study because I know the next speaker is going to talk about that and we're going to have a separate discussion. So I'll just leave that out for now. So again, when to switch? We need to switch or consider switching if the individual is virally suppressed. Very important to really go through the patient's full ARV history, including virological responses, past toxicities and intolerances, and any cumulative resistance test results. Hepatitis B negative, there should be no previous virological failure or any INSTI or NRTI mutations, and no previous intolerance to any of the drugs. So if somebody is intolerant to one of the drugs you're going to use, and you're going to use only 2, you cannot put them on that regimen. So this is sort of a very crucial question. Do we have to change successful ART? By successful ART, I mean somebody is taking an ART regimen, there are no drug interactions, they are virally suppressed, they are well with no toxicities. Do we have to change just because the literature says, or just because studies have shown that there is a better regimen? I think this is a controversial topic. I think everybody will have their own opinion. First of all, we need to, if we consider changing, we need to ensure that the criteria is fulfilled and the change is being made for a medical reason, either reducing toxicity or pill burden or cost or drug-drug interactions, and not for the sake of changing. As we heard from Dr. Neha and from several other speakers, none of these new regimens are also without their own problems. We know the newer drugs, they do have their toxicities, especially obesity, metabolic complications, and all this may come out in the years to come. So I really feel the current regimens are still efficacious if they are well tolerated. And actually WHO says that if there is a regimen that is actually working well, you don't have to change it. So in my practice, I don't change patients who are doing very well with their own regimen. I just keep them on it, obviously monitor for toxicities. The longer you're on drugs, the more you worry about long-term sort of accumulative toxicities. But yes, we need to monitor that. But if there's no signs of it, I would keep them on the same regimen. So this is my last slide. What are the take-home points? We have several excellent regimens for initial ART. Majority are INSTI-based. But we have to consider this on an individual patient based on their comorbidities, other medications they take, and their preference. Probably INSTIs, especially DTG, is the preferred medication, especially in women who are pregnant or trying to conceive. Bictegravir still doesn't have approval for use in pregnancy. Definitely DTG 3TC is an option for initial therapy or as a switch therapy in patients who are virally suppressed. But it's very important to make sure that the prerequisites are fulfilled and also the patient can tolerate it. For patients who are virologically suppressed, we do have the long-acting INSTIs, and I think the next talk is going to deal with that, so I'll not go into it. And once again, I thank the organizers for giving me this opportunity. Thank you.
Thank you, Dr. Rajiv, for excellently covering all the issues. You have talked about the INSTIs, you have talked about the switch, and you have talked about the two-drug regime, and of course, you have skipped the long-acting drugs for obvious reasons. Thank you for excellent talk. Thank you. Next, we have a talk on by Dr. Harsh Tasini and Dr. Mittu Kumar Daswandria from Ahmedabad, and they will be talking on the important issues which Rajiv didn't touch on the issue of long-acting two-drug ARVs, whether we are going to use them or not. Please start. Thank you.
Good morning, everyone. I would like to thank Dr. Maniar for giving me this opportunity. I will be talking about the long-acting ARTs. So why do we need long-acting ART? The biggest advantage is to improve adherence by dealing with the reasons for lack of adherence, like forgetting, being away from the home, change in daily routine, depression, pill fatigue, etc. It will also make the patient's life pill-free, and it can also improve the adherence in pre-exposure prophylaxis. So these are the current either approved or in the late phase of clinical trial agents which are long-acting. We'll be discussing about it in the next slides. The most widely studied and recently approved for the treatment of PLWH with virological suppression on stable regimen without history of virological failure and without known or suspected resistance to either drug. Cabotegravir is an INSTI which is structurally similar to the DTG. It has high barrier for resistance and available in oral as well as long-acting injectable forms. Rilpivirine is an NNRTI which is also active against many NNRTI resistant mutation. It has low barrier for resistance and also available in both the forms. So how do we approach for the long-acting cabotegravir and rilpivirine? To begin with, we need to start the initial oral therapy with 30 milligram of cabotegravir and 25 milligram of rilpivirine for 1 month to check for the tolerability. If patients tolerate it, then we can start on the long-acting injectables. To begin with, we need to give the initiation schedule, which contains the single dose of cabotegravir 600 milligram and rilpivirine 900 milligram for the every month regimen, and 2 doses of the same dose 1 month apart for the every 2 month regimen. For the maintenance every month regimen, we need to give cabotegravir 400 milligram and rilpivirine 600 milligram every month, and for every 2 month schedule, we need to give the higher doses of cabotegravir and rilpivirine every 2 months. For the missed doses, if patient is planning to miss dose for more than 7 days, then we need to switch to the oral cabotegravir and rilpivirine for up to 2 months till the patient resumes the long-acting injectable ARTs. If the missed dose is less than 7 days, then we can continue the same long-acting injectable without switching over to oral therapy. If an unplanned interruption occurs, then we need to reassess the feasibility of continuation of long-acting ART. And if it is feasible, then if the duration of delay is less than 1 month, then we can resume the maintenance schedule as soon as possible. And if the duration of delay is more than 1 month, then we need to restart from the initiation schedule. These are the evidences for the long-acting injectables when compared with the standard three-drug oral daily pills. In the last ATLAS-2M trial, every 2-month regimen was compared with the every month regimen, and it shows the non-inferiority as compared to the every month regimen, which on the basis of which it is recommended as a 2-month regimen. So the capsid inhibitor, lenacapavir, which is a first-in-class capsid inhibitor, it inhibits the capsid assembly, disassembly, nuclear transport, and virus production. In a Capella trial, they will evaluate the safety and efficacy of oral lenacapavir in PLWH with multi-resistant virus 10 whenever added as an add-on to a failing regimen. In a preliminary results, it was shown to be safe, well-tolerated, and led to a rapid and clinically relevant decline in viral load. In another trial known as Calibre Trial, the data for which was published in recent CROI, subcutaneous lenacapavir every 6 months was compared with the oral tenofovir, alafenamide, emtricitabine, and bictegravir, and it was found that it is also non-inferior and having efficacy of almost 88 to 90%. So this lenacapavir is promising in view of a very long interval of doses. Islatravir is a novel nucleoside reverse transcriptase translocation inhibitor. It has multiple mechanisms of action. 2-fluoro group in islatravir will protect it from metabolism by adenosine deaminase, which will lead to the prolonged half-life. It has potency against resistant HIV variant. And in a dose-ranging trial, islatravir plus doravirine was at least as effective as the 3-drug regimen of doravirine, TDF, and lamivudine. It can also be given as a subcutaneous non-degradable implant, but in a major setback to islatravir in December 2021, FDA halted all the studies of islatravir in view of decrease in CD4 cells and total lymphocytes. So we don't know about the future of islatravir at present. Other classes, monoclonal antibodies, ebalizumab is an humanized IgG against extracellular CD4 domain, which will prevent the HIV entry. It is currently recommended in combination with other ART for patients who is failing ART due to multi-resistant virus. The dosing schedule is 2 gram IV dose followed by 800 milligram every 2 weeks. Due to its IV infusion and short duration of interval, it is not a very suitable option for long-acting ART. Another monoclonal antibody is leronlimab, which is directed toward the CCR5. It has synergistic effect with maraviroc and also active against the maraviroc resistant virus, but we need tropism assay before starting the leronlimab, and it is given as a subcutaneous every week, which can be self-administered by the patient, but currently it is under the trial only. So all the currently available long-acting ART has limitations, mainly the logistic limitations, which include the frequent clinic visit, which will be challenging for our rural populations. Long-acting rilpivirine will require the cold chain preservation, painful injections, and probably high cost as compared to the oral ART will be the limiting factors. Pharmacokinetic tail phenomenon, which is in which there is a suboptimal concentration of the drug in plasma following the cessation of long-acting ART, can lead to the occurrence of drug resistance. Drug-drug interaction, which every speaker has spoken, that also applies to the long-acting injectables also, like interaction with the anti-TB therapy, drug interaction with other drugs like azole, antifungal, macrolide antibiotics. Delayed onset ADAs, which are not known yet, can complicate the management with long-acting injectables. HBV co-infection and pregnancy are currently limiting factor for the long-acting ARTs. This is the peak tail phenomenon in which suboptimal concentration will last in the plasma after stopping the long-acting injectables, which can lead to the drug resistance in a virologically non-suppressed patient. To overcome these limitations, many new formulations are coming, and promising one is the long-acting slow-release ART with nanoparticle of cabotegravir, in which the single dose of nanoparticle cabotegravir in a rhesus macaque lead to the plasma cab level more than 90% of the protein adjusted inhibitory concentration up to 365 days. So it has a potential to be become a molecule which we can use once a year as a long-acting ART. Another one is long-acting removable drug delivery system, currently being evaluated for the dolutegravir. it has an advantage that you need only to implant it, then it can be refilled every time. And whenever, if you want to discontinue that, it can be surgically removed also. And there are other methods also for the new formulations. To conclude, it looks promising to overcome the barriers of stigma by improving patients' privacy and reducing the psychological and social burden associated with the daily intake of anti-HIV pills. Limitations are overcome. It can revolutionize the HIV care in future and may lead to the practical cure. By just giving by once a 6 month or once a year dose, it can lead to the practical cure of HIV. But these are in the trial forms only. Thank you.
Thank you, doctor. You have covered all the important issues on the LAART.
LAI, yes.
So, and you need to consider the people for whom cost is an important issue, and there are drug interactions, and there will be issues of therapeutic drug monitoring also. That's again important.
Yes, sir.
Thank you for a nice presentation.
Thank you.
Thank you.
You had very interesting talks in the morning, and everybody is now aware that a lot of HIV is there, a lot of guidelines are there, a lot of drugs are there, but every case is challenging, as we've seen earlier. So now we have some challenging case studies which all of us encounter in our day-to-day practice. So we have some very interesting cases lined up, and I would now request Dr. Vinay Kulkarni from Pune to take us through the first interesting case study. Over to you, sir.
Yeah, thank you. Good afternoon, and thanks for giving me this opportunity. I am just going to present a very interesting case. So this is a 48-year-old man who presented with slowly spreading painless lesion on his penis with minimum discharge since 1.5 years. The lesion started from his foreskin with small ulcers and slowly spread to involve the ventral glands in 2 to 3 months. The lesion was painless, no urinary symptoms. Patient denied attempting sexual intercourse due to this lesion. In the treatment, past treatment lesions did not subside with repeated treatment with antibiotics and antivirals, antifungals also. 2 excisional biopsies were done in 2019 which showed non-specific changes of ulceration with granulation and severe acute or chronic inflammation. His diagnosis of HIV was about 5 years ago, and he was on zidovudine, lamivudine, nevirapine regimen for 3 years. His CD4 count was 350 and HIV viral load was undetectable. He had undergone a circumcision when he was diagnosed with partial phimosis 3 years back. Histopathological examination at that time was not done by the surgeon. In his personal history, he is a daily wager by profession. He is a smoker, tobacco chewer, history of multiple partners in the past, married since 23 years. His wife is 45 years old, HIV positive, diagnosed at the same time as husband. Son is 15 years old and HIV negative. Her HPV screening for cervical smears, cervical fluid was negative. General examination, patient was alert, conscious, well-oriented and cooperative. He had bilateral inguinal lymphadenopathy, left side more than right side. Systemic examination was non-contributory. At presentation, he had this lesion. It was a large pink-colored proliferative growth with nodular surface and cauliflower-like projections in few places. Involved the entire shaft of penis from ventral side, sparing the urinary meatus. There was minimum urine discharge at places. This was the lesion, almost covering the entire shaft. On palpation, it was soft, non-tender growth which did not bleed on touch. The differential diagnosis concerned were condyloma acuminata, squamous cell carcinoma of penis, and this was our case. It looked totally different from the other. The plan was a neurosurgeon and a plastic surgeon was involved in the opinion. A CT scan of abdomen pelvis was advised before any kind of intervention, and excision biopsy was planned. His CT scan with FDG showed activity of cutaneous thickening involving penile prepuce and glans penis, increase in size, extent and FDG activity of residual bilateral external iliac and inguinal nodes, and whole body PET scan was advised to rule out secondaries. No metabolically active disease was seen anywhere else at that time. On histopathological examination, it was found that there was marked hyperkeratosis and hyperplastic squamous epithelium, neutrophilic infiltrate at few places with ulceration and microabscess formation. You can see this hyperkeratosis and hyperplastic squamous epithelium and infiltrates with neutrophils, etc. in the microabscesses in the epidermis. There were plasmacytic infiltrate in the upper and lower dermis. These were the kind of epidermal extensions into the dermis. There was a downward irregular proliferation of squamous epithelium with sharp borders and minimal stromal reaction. Pseudoepitheliomatous hyperplasia resembling papillary architecture was noted at places. Atypical squamous cells, large in size and with vesicular nuclei, were seen in the epidermis. So, there were no lymphoid follicles, there were no epithelioid granulomas, there were no fungal elements, there were no parasitic elements, and minimum squamous cell ATP was seen. IHC staining was done with P16 and P53, but both were negative. P16 is a surrogate marker for HPV. P53 is a protein that functions to regulate apoptosis of the cell cycle, and it was also negative. Fine needle aspiration of the lymph nodes was done, which was negative for atypical cells. So it was diagnosed as a case of pseudo-hyperplastic squamous cell carcinoma. The tumor was classified TNM stage T4N1MO. Wide local excision was followed by split thickness skin grafting from left of thigh. Partial penectomy was with reconstruction helped our patient recover with proper organ function and no issue with micturition and penetrative intercourse. So this was the intrasurgical photograph. This was the graft done. This was the final outcome. CA penis, it constitutes only 0.3 to 0.5% of all male malignancies. Of all the penile cancers, squamous cell carcinoma is the most common, which is about 95%, and risk factors include lack of early circumcision, poor hygiene, smoking, infections like HPV 16, 18, multiple partners. Patients with HIV are at 8-fold high risk of penile cancer with causal link with immune suppression. Now, WHO classifies penile squamous cell carcinomas basically on the presence of or absence of HPV infection. Non-HPV related squamous cell carcinomas are pseudohyperplastic, pseudoglandular, verrucous carcinoma, carcinoma cuniculatum, papillary cell carcinoma, adenosquamous carcinoma, and sarcomatoid carcinoma. Whereas HPV related squamous cell carcinomas are basaloid cell carcinoma, papillary basaloid cell carcinoma, warty basaloid cell carcinoma, clear cell carcinoma, lymphoepithelioma like carcinoma. Pseudo-hyperplastic squamous cell carcinoma is very slow growing, well differentiated, non-verrucous, pseudo-hyperplastic endophytic growth affects foreskin. It is associated with squamous hyperplasia and lichen sclerosus like lesions of the foreskin, and probably the first phimosis was associated with this when the circumcision was done, but there was no histopathology at that time. A distinguishing histopathological feature of carcinoma is irregular downward projection of squamous epithelium with minimum atypia. Treatment almost always constitutes of reconstructive surgery. Can penile cancers be prevented? Yes. Responsible sexual behaviors, circumcision, genital hygiene, avoidance of tobacco, and HPV prevention through vaccines and all, we can prevent HPV infections and reduce the cervical cancers. What about vaccination? We know there are 2 types of vaccines available, and probably the third one would be available by this end. I think Indian Serum Institute is coming out with HPV vaccine. They focus more on cervical intraepithelial neoplasia, cervical C, and not tried extensively for male HPV cases. But there are studies that show that they are effective as compared with encountered in female patients. Recommended doses are given below, but I think gradually we are shifting again there from 3 doses to 2 doses and 2 doses to 1 dose also, because recently British have started recommending single dose vaccination also in girls of pre-adolescent age. Now, this was the case. It's a very rare condition, and there has not been a single case of PHSSC reported in HIV infected patients yet, according to our our literature search. So probably this is the first case report of PHSSC in a HIV infected person. I thank my colleagues who did that. Thank you.
Thank you, Dr. Kulkarni. It indeed was a nice case, and thanks for making us part of the first case globally. We move on to the visit to the museum, where we are going to see a museum of infections by Dr. Kanishka Davada from Mumbai. Over to you, Doctor.
Thank you so much, sir. A very big thanks to Maniyar sir for inviting me. He's always very, very supportive of juniors, so very thankful for that. With that, I'll just start the case. So this was a 53-year-old guy who presented with 2 months of fever, anorexia, weight loss. And so the routine CT workup which we do for such situations revealed all of these things. So, very prominently you can see at near the center of the screen, necrotic lymph nodes. There was also splenic microabscesses, and he was found to be HIV positive. So this was all elsewhere before he came to us, and the biopsy wasn't attempted at this point, and he was started on thrice weekly ATT. It's a little bit of an older case, so some of the older guidelines were being used, and he took it via RN-TCP, and then let's see what happened. So a month later, he was started on the TDF, FTC, efavirenz, and CD4 count at baseline was 1. Now he had very poor adherence with both his ATT and his ART, with approximate reported adherence of only about 30 to 50%. But still there was some partial improvement in his symptoms, and he took ATT for 6 months and then stopped. And CD4 count done at this point was around 75. But about 1 month after stopping his AKT, there was again a recurrence of his symptoms. The same things, fever, weight loss, fatigue. He finally presented to us at Hinduja. I was at Hinduja at that time, and this was seen, right suprahilar patchy consolidates were seen. And we asked for a repeat ultrasound, scan, fundus, everything. So the ultrasound revealed again some hypoechoic lesions in the liver, which was like, there was only a single lesion in the earlier scan. Now there were multiple lesions. There is a moderate ascites and splenomegaly with retroperitoneal nodes. CD4 we found was 33. So now what were the things on the top of our head? So this could have been, so initial biopsy was not done. So this was a case with low HIV with low CD4 with generalized lymphadenopathy, lung lesion, liver lesions, splenic lesions. So we were thinking of disseminated TB, which may have, either initially only been resistant, primary resistance, or could have developed resistance on treatment because the adherence was so poor. Other possibility which we kept in mind was iris, disseminated MAC, lymphoma. Very rarely there can be rhodococcus with a liver lesion and visceral abscesses. So these were the differentials. So from these, disseminated resistant TB was the one which seemed to fit the best. The other diagnosis had some point against them. So like iris was thought to be unlikely because patient was non-adherent, so why will there be iris? Then rhodococcus and disseminated MAC are a little bit rarer, and lymphoma would not explain the lung lesions and the ascites. So our main clinical suspicion was disseminated resistant TB, and the scanning further revealed this kind of thing with a lot of miliary nodules and again splenic hypodensities, miliary nodules, this sort of thing. So omental biopsy was done, which showed resistance. The probe E absent. So these are the old gene expert, done by the old methods. And while awaiting the results of culture and DST, we started the patient on the second line AKT, and a fundoscopy was also asked for. So now what to do about the ART? So now this patient has been on efavirenz-based ART, and he has been non-adherent with it, and he has come with a opportunistic infection which seems to have progressed. So now the options are, do we continue the same regimen, do we change to a new effective regimen, or we stop ART altogether and deal only with the opportunistic infection first? So, there are again several advantages and disadvantages to each of these options. So I'll take that in this table, right? So continuing the failing regimen will cause further resistance and also add to the pill burden and lot of drug interaction. So you can imagine patient on second line AKT and on second line ART. So many interactions are possible. Initiating the new effective regimen is also a problem because there can be a lot of iris issues and again lot of pill burden. Stopping ART altogether is also not very attractive because as it is, the patient is having very low CD4. So in this situation, sometimes like how my mentor Dr. Soman guides us, sometimes we use this sort of holding regimen and we use only 3TC monotherapy. There are two references for this. There are some studies as well. It is not something completely invented by us or anything. But basically it deals with these shortcomings that I just discussed. So something is going on, so rapid viral rebound does not happen. Further development of resistance is not happening because we are not giving NNRTIs, and 3TC mutations we are okay with many times even if they develop. We are avoiding the iris because we are not giving the new regimen, and the pill burden is also not so bad, interactions are also not so bad. So we chose this holding regimen strategy and we went ahead, and the fundoscopy revealed this kind of picture. So you can see there are yellow exudates and some retinal hemorrhages. So this was suggestive of CMV retinitis. And patient had a lot of cost issues, so he refused sort of systemic CMV therapy. So we gave only intravitreal therapy. And after this, he developed septic shock, and he was very down and out, but somehow he improved and got discharged. But long-term adherence and prognosis remains guarded. So this was a case with resistant TB, resistant HIV, and then finally CMV. Just a little bit, I'll touch on the CMV. So also, anti-CMV drugs only stop CMV replication, and they cannot eliminate the virus. So in the absence of adequate immune recovery, anti-CMV treatment must be continued indefinitely. Monitoring of therapy is by serial fundoscopy, first at diagnosis, then at 2 weeks, then at 1 month. And only after immune recovery has occurred, you can do every 3 months. Relapse or non-relapse can be due to many reasons. So early relapses are usually due to inadequate drug levels. Late relapses can be due to resistance and inadequate immune recovery. Most authorities recommend that effective ART should be deferred for at least 2 weeks after therapy for CMV has started. Otherwise, there can be immune recovery uveitis, which itself is sight-threatening. So this was, and treatment of immune recovery uveitis will also have steroids in the picture. So with that, I come to the end of my case, and these are my acknowledgements.
Thank you. It indeed was a real nice case, and some kind of a case scenario which is the real challenge which makes HIV interesting. Thank you. We move on to the next speaker, and we come to the challenging cases in the late presentations in this pandemic era. And for this, I would like to invite Lieutenant Colonel retired Dr. Sumit Arora, who is a dear friend and who is at the Apex Immunodeficiency Center at Base Hospital. Over to you, Dr. Sumit.
Thank you, sir. I'd like to thank the organizers, especially Dr. Manyar, for inviting me to speak at this esteemed forum. I'll be presenting a couple of cases which we saw, lots of cases we saw in the pandemic era, in the COVID pandemic, where patients presented very late because they were stuck in lockdowns or they were scared to come to hospitals even when the lockdowns opened, and presented very late with multiple OIs and complications.
I'll start with my first patient. He was a 40-year-old soldier. He presented in June 21 with 3 months of fever, dry cough and weight loss. 3 months back he was on leave at his hometown, and lockdown was placed during the second wave, and he could not report back to his military unit. He could not report sick, and he stayed at home. And after 3 months, when he had the courage to go to the hospital, he reported with these symptoms. On evaluation, he had pallor, oral thrush, and he had a large right supraclavicular lymph node enlargement. There was a superficial skin ulcer over the right groin and left, this is a mistake, it's a left groin and perianal region. He had hepatosplenomegaly, and his fundus was normal. This was the skin lesion. This is along the scrotum and the perianal region. Well demarcated shallow ulcer with a clear base. Investigations revealed anemia, leukopenia, platelet count was normal. His LFT was normal except for a high alkaline phosphatase. KFT was normal. He was found to be HIV positive. His CD4 was 48. HbS-Ag and HCV were negative. His X-ray chest showed bilateral upper lobe and right middle lobe nodular opacities. An ultrasound showed hepatosplenomegaly. His biliary tract was normal. A CT chest and abdomen was done, which showed multiple areas of consolidation with surrounding ground glass opacities in the bilateral upper lobes, the right middle lobe, and diffuse small peribronchovascular and subpleural nodules all over the lung fields. There was mild enlargement of the mediastinal and retroperitoneal lymph nodes, subcarinal node which was 2 centimeters, and hepatosplenomegaly. We did a bone marrow aspiration and biopsy in view of bicytopenia with normocytic normochromic anemia, but the marrow did not reveal much. It was a cellular reactive marrow. His serum cryptococcal antigen was negative. The supraclavicular lymph node FNAC was also inconclusive. It showed chronic inflammatory changes with no granulomas, AFB negative, gene expert negative. Then we did a EBUS guided subcarinal lymph node FNAC which confirmed tuberculosis. The MTB gene expert was positive and there was no rifampicin resistance. And we also did a skin biopsy which was awaited. In the meantime, we got the, since we got the subcarinal lymph node FNAC, we started him on ATT. However, initially on day 1, we started him on cotrimoxazole and fluconazole prophylaxis, and empirically started him on valacyclovir 1 gram BD, suspecting as one of the differentials of the skin ulcer being HSV, as one of our previous speakers had discussed this. We started first line ATT on day 7 when we got the gene expert report. However, within 2 days of starting ATT, he developed jaundice with a bilirubin of 6 mg/cent. His AST/ALT was not very high, but alkaline phosphatase had jumped to 1125 and GGT was 620. So he developed a predominant picture of cholestatic hepatitis and acute kidney injury. His creatinine had shot up to 2.1, sodium was 126, potassium 4.8. Such a sudden rise in hepatic and renal parameters, we thought of a drug reaction most likely to cotrimoxazole. Since he had taken only 2 doses of ATT, we were not convinced that ATT would be the culprit, and Septran is known to cause AKI as well as cholestatic hepatitis. Though there was no eosinophilia, no new rash, we stopped cotrimoxazole and modified ATT to a non-hepatotoxic regime. His workup for AKI did not reveal, urine analysis did not reveal any active sediments or eosinophils, and urine was sterile and there were no pus cells. So we thought we'll modify and change, stop Septran and modify ATT and wait and watch. This ultrasound abdomen did not reveal any biliary abnormality or hepatic abnormality. In the meantime, the skin biopsy report came and histopathology was not very conclusive, but we found that skin biopsy specimen was positive for CMV DNA. So we, and about 8 days had passed and valacyclovir had shown no response to the skin ulcer healing. So we put the patient on valganciclovir. His LFT and KFT recovered spontaneously with drug modifications over next 1 week, and we gradually reintroduced first line ATT, the preferred regime. He tolerated it well this time. We did not restart cotrimoxazole. His skin ulcer he started healing in 1 week of valganciclovir and showed significant healing over 2 weeks. After reintroduction of ATT, we started him on TAF, emtricitabine, dolutegravir after about 10 days of reintroduction of ATT. Patient tolerated this well, and around day 34, patient was afebrile, he had gained weight, he had started eating well, his oral thrush had vanished, his skin lesion had almost completely healed, he was feeling much better. So we discharged him and advised him to come back to us after 4 weeks. However, he reported back to us within 10 days with recurrence of fever, cough, and again decreased appetite. Clinically, he was febrile, he had tachycardia, there was no tachypnea, no dyspnea, no increase in lymph node size, the right supraclavicular lymph node, and his chest was clear. His hemoglobin was 10.2, TLC 3800. LFT had not really worsened. AST ALT was marginally high. ALP was 188, GGT still high. KFT normal, albumin 2.8. His chest X-ray showed diffuse nodular opacities all over the lung fields. Initially, the low zones in the X-ray were normal. His HIV RNA had dropped to 98 copies per ml. So there was a remarkable drop in HIV viral load. This was his X-ray. His sputum examination did not reveal any new findings. Zn stain, gram stain was negative, culture was sterile. This time his sputum gene expert was, MTB gene expert was positive and rifampicin sensitive. So we labeled him as a case of TB iris. However, we incidentally found that his serum calcium corrected values were high. His corrected serum calcium was 11.6 and 11.8. So we did a phosphorus level which was normal, vitamin D level was normal. We sent a parathyroid hormone level which was very low. So we made a diagnosis of parathyroid independent hypercalcemia. His thyroid profile, cortisol was normal, skeletal survey did not reveal any lytic lesions, and serum ACE levels were normal. So based on all these findings, we made a diagnosis of TB iris with granuloma associated hypercalcemia and treated him with tablet prednisolone with a good response. Patient recovered and was discharged. 3 months later, patient was asymptomatic. His counts had improved. His LFT alkaline phosphatase was, GGT was still high, albumin normal, calcium normal. 6 months later, a patient is absolutely asymptomatic. His HIV RNA is well suppressed and his X-ray chest had become absolutely normal. His serum calcium was normal. With that, I'll come to my next case. This is a 39-year-old male who was an HIV patient diagnosed in 2011 and started on zadovudine, lamivudine, nevirapine. Somewhere down the line in 2016 or 17, he was switched to tenofovir, lamivudine, efavirenz. We didn't know the cause, probably anemia or maybe just immunological failure without a viral load testing. He stopped his ART in March 2020 during the first lockdown and reported to the local ART center with fever, cough and weight loss of 2 months duration in August 2020. His X-ray chest at that center showed bilateral pulmonary nodules all over the lung fields. Sputum, CBNAT and Zn stain were negative. He was started on empirical ATT in August 2020 and advised to follow up. He did not go back to the ART center, stayed at home, continued to take ATT without any response. He had persistent fever, progressive weight loss. generalized non-pruritic papular rash, dysphagia, and loose stools when he reported to us. Clinically, he was cachexic, bedridden, pallor, oral thrush, papular rash all over the face and trunk, non-pruritic rash. He had pedal edema, lethargic, he was oriented to time, place and person, terminal neck rigidity, no signs of raised ICT, moving all four limbs, bladder, bowel incontinence, and his fundus was normal. These are his lesions. I think we all can guess what this must be. He had severe anemia, transaminitis, low albumin, LDH was high, CD4 19, HIV RNA more than 10 lakhs, sputum AFB, CBNAT negative, serum CRAG negative, chest X-ray, CT chest and abdomen showed fine bilateral nodular opacities all over the lung fields, all lobes, hepatosplenomegaly, MRI brain was showing cerebral atrophy, no meningeal enhancement, no focal lesions. CSF showed only one cell, lymphocyte, proteins were marginally raised, sugar significantly low, his staining was negative, ADA normal, CBNAT was negative. So we made, this was probably a fungal meningitis based on low sugars, possibly tubercular meningitis. We did a bone marrow aspiration and biopsy and a skin biopsy of his lesions and started him on empirical amphotericin, because we were quite convinced that the skin lesions and the systemic presentation was disseminated histoplasmosis. However, we continued the ATT because we didn't have a definitive diagnosis. So the skin biopsy and bone marrow aspirated biopsy confirmed our suspicion. These are multiple yeast cells inside macrophages in the bone marrow. So we labeled him as disseminated histoplasmosis. By the time we got the diagnosis, he was on amphotericin for 1 week. The response was good. He was improving. However, we noticed that he was not moving his lower limbs. On evaluation, we found that he had developed flaccid paraparesis and hyporeflexia, and power was grade 1/5 and 2/5 in the lower limbs. No sensory deficit, upper limbs and cranial nerves are normal. MRI spine normal, NCS suggestive of AIDP. CSF was still similar, very few cells, high proteins, low sugars.
Sumit, try to wind up now. We're already.
So CSF DNA, CMV DNA was positive. We labeled him as a case of CMV radicular neuropathy. Treated him with valganciclovir. Switched from amphotericin to itraconazole. Switched his ART2, protease inhibitor plus integrase inhibitor. This patient, after 8 weeks of discharge, sent me this video. From being bedridden, he's started walking with a walker. He had almost completely recovered from CMV radicular neuropathy, and presently he is on TAF, emtricitabine, dolutegravir. All prophylaxis have been stopped and he is walking with a stick, virologically well suppressed. Take home message: we should look for CMV in advanced disease, and CMV may present without retinitis.
Thank you, Sumit.
Thank you. Sorry for the
I know you get carried away because there were such interesting cases. We all got carried away, but in the interest of time, we have to wind up. So it was really interesting, and we saw that TB remains a common infection, but we have to look beyond, especially in the setting of HIV. So we'll quickly move on to the last case. We have a speaker all the way from Jodhpur, Dr. Deepak Sharma, who will be presenting an interesting case of invasive aspergillosis and tuberculosis. Dr. Deepak Sharma, over to you.
Thank you, sir. And I'm very thankful to Dr. Maniar, sir, to providing me this opportunity. And I start with my case. A 45-year-old female presented with a history of fever, vomiting for 3 months. And with the interrogation of further history, she also had history of weakness on left upper and lower limb. And she recently diagnosed as the HIV and HBsAg co-infection and started on the TLD regimes with CD4 of 71. Along with this history, she also complained of generalized weakness and dry cough from last 6 months. And on physical examination, we able to find only left hemiparesis, and we have to rule out the opportunity infection in this patient. And on the investigation, we found mild anemia with the raised inflammatory markers, and her chest X-ray is showing bilateral heterogeneous opacity, as she was not producing sputum, so we planned for the BAL. And as she had hemiparesis, we went for CT and MRI that suggestive of multiple ring enhancing lesions that are consist with the tuberculoma. And her CT thorax was suggestive of the diffuse centrilobular nodules with the tree in bud pattern. That is, radiologists say it is consist with the tuberculosis. So, and the BAL fluid report is also consist with the tuberculosis, the AB positive with gene expert positive with the rifampicin resistance not detected. So, and other investigation for opportunistic infections are found to be negative, and viral load of HIV and HBsAg are raised, and so we have put our diagnosis as HIV and HBsAg co-infection with disseminated tuberculosis, and we have started with the extra dose of dolutegravir, and we have started anti-tubercular treatment also. But the galactomannan which we have sent with the admission are found to be positive in all the fluids, in the BAL fluid, as the serum, as well as the CSF. And we revise our diagnosis, and we make the final diagnosis of HIV and HBsAg co-infection along with disseminated tuberculosis and invasive aspergillosis. So patient is not satisfying the clinical, host criteria, but patient is satisfying the clinical and mycological criteria. And patient is also started on the antifungal treatment, and now patient is very well and on follow-up. So then I have searched the literature regarding the aspergillosis and found that a large cohort published in the 2000 showed the aspergillosis is not a common condition with the HIV. But the large post-mortem study of 16 years from the invention of this HIV found that the invasive aspergillosis is the second most invasive fungal mycosis was associated in a patient of HIV after the pneumocystis carinii. So it is less diagnosed condition, that less incidence, and they also found that prevalence did not significantly change despite the introduction of the heart. And I also searched for the Indian data, and also Indian data is very small, and this study is done in the 71 patient, and this found again the second most invasive mycosis in a patient of HIV. And I also said the co-infection of the aspergillosis and the tuberculosis in a patient of HIV, and I can able to find only one case report, and the author also said that despite their best effort, they could not able to find more literature regarding the invasive aspergillosis and tuberculosis in a patient of HIV. And the most of the study which is focusing on the aspergillosis and HIV are related to the chronic pulmonary aspergillosis, and they are mostly with the recovered patient of the tuberculosis. So regarding the emerging risk factor of the invasive aspergillosis, the ISAM clearly says the HIV is very important emerging risk factors, and if we are looking to the EORTC criteria, and the studies, this study published in the CID in 2015, it is clearly said patient who are satisfying the clinical and microbiological criteria, only 50% patients are able to satisfy the EORTC criteria. It means with the EORTC criteria, we are missing 50% cases of invasive aspergillosis, and author clearly mentioned that HIV infection with CD4 less than 100 should be included in the EORTC host criteria for diagnosis of invasive aspergillosis. And what are the important radiological findings that guide us for the diagnosis of invasive aspergillosis? Along with the classical criteria from the EORTC, like HELLO, reverse HELLO, air crescent site and cavitation, the patient with non-neutropenic host factor, consolidation, nodules, and tree in bud nodule are very, very important, and they were found very early and very much helpful for the diagnosis of invasive aspergillosis. And ISAM has clearly said that EORTC criteria is actually not a realistic criteria for diagnosis of invasive aspergillosis, especially in non-neutropenic patient or especially in patient of HIV. So they have clearly mentioned that centrilobular nodules with tree in bud pattern should be included in the radiological criteria, and as it is a non-specific, so most of the radiologists are mentioned as the disseminated tuberculosis rather than the disseminated fungal infection. So by this case, the invasive aspergillosis and tuberculosis co-infections are uncommon in the HIV, and the active search of invasive aspergillosis should be done in a patient with HIV with a CD4 count less than 100, and early radiological finding like centrilobular nodules and tree in bud should be searched for as a invasive aspergillosis, even with the diagnosis of that tuberculosis, and the delays of the diagnosis of invasive aspergillosis is further increases the mortality of HIV. As the literature says, the invasive aspergillosis was associated with 80% mortality in patient of non-neutropenic patient. Thank you.
Thank you, Dr. Deepak. You have highlighted very important issue, possibility of coexistence of tuberculosis and aspergillosis. Another issue is when you are treating the patient, because there is a drug interaction between rifampicin and voriconazole, so that has to be also be taken care of.
Yes, sir. So we have started patient on rifampicin sparing regime with the voriconazole, and patient is doing well, sir.
Right.
Thank you, Dr. Sharma. I think we have come to the end of this particular session, and it was a wonderful session. And point to take home is that in most of the patients with advanced disease with low CD4 count, they have multiple infections. People have, what you saw, they made an attempt to find multiple infections and treat them with heartening results. So another part which I wanted to add here was that when we were looking at the application of long-acting ART, the subcutaneous injectable one, maybe it will have an application in PrEP, because these are the people amongst the high-risk population who continue to indulge in high-risk behavior. Injectable subcutaneous injections taking once a month or once in 2 months may have a good application in PrEP. Thank you very much. With those comments, we
Thank you very much, Dr. Diwan, for that input, and thank you, the chairpersons, for doing a wonderful job. Getting on to the session 3, before we begin with session 3, humble request, people who are checking out today, they are requested to get their checkout done and keep their baggages in the lobby so as to get started. There's a wedding in the hotel, so they have requested us for the needful. May I call upon Dr. Sajid Kumar, who is a convener of National Medical Commission Nodal Officer for the COVID control and the management team, who is a national AIDS trainer for WHO, NACO, and Government of India, and first Kerala physician for AIDS management, to honor us as a moderator for the next session. Along with him, Dr. Ravindran, Dr. Ruby Bansal, and Dr. Dipanjay Bandopadhyay to chair the sessions, please. There's one change into the third session, since Dr. Panda, who was going to talk on session 4, his flight has been preponed, so he'll be speaking first.
Yeah, at the outset, on behalf of my co-chairs and on my own behalf, let me thank the organizers, particularly Dr. Maniar, for giving us this opportunity. And as we all know, in spite of all the advances in ART, still we are finding lots and lots of cases just like we used to find in the earlier days. Even though the glorious picture of ART as a success has been projected, still all those issues are coming back in different forms to all of us. So in this session today, we have got 2 plenaries and 4 case study presentations. And yeah. So as has already been announced, Dr. Jayant Panda is going to discuss about the issues which we had to face during the COVID epidemic, which has been an issue for all of us, dealing with various cases and even outside the specialty of general medicine and infectious diseases. And I am sure HIV has been behaving differently with COVID, and let's hear him about his experiences. Over to Dr. Panda.
Thank you, sir. It's a pleasure. The KOLs of HIV medicine are here. Professor Maniar, Professor Riwari, Professor Chapelet, and then one and all. If I take name, this little time will be lost. So I salute all for the care you have given during the pandemic. I thought, because it's immediate post-pandemic, let us review the impact of COVID on HIV and especially people living with HIV, so that we can take our experience further. I'll just tell the COVID-19, which all of you know, and how HIV might make COVID-19 a risk worse or better. Still, it's a debate. And HIV impact on the COVID-19 and the treatment, the PrEP, and the SS. So all of you know that we went through a pandemic which is a never before experience and lifetime experience. And then all the strains, maybe alpha, beta, gamma, delta, omicron, what all you have faced, has some impact or other in the form of post-COVID symptoms as well, and we all have fought, and the pandemic is still on. So it reminded us few horrible experiences like SARS and the MERS are not taking you there in view of running late in time. And directly I'll go to the collision, the current state of the HIV pandemic, and it has been well discussed in the House that pre-COVID in 2019 we had around 38 million cases worldwide, and in different regions the cases were different. And let us see the susceptibility and disease severity. Well, what happened? I'm starting with a case, a index case. It's a real life case, and I have discussed with many of my colleagues and the senior KOLs about this case. A friend of mine, 52-year male, was an IT professional, and he was positive for last 15 years and well controlled only with TLE, and CD4 was around 889 and viral load was target not detected. He became positive in the second wave in May 21. Maybe it was a Delta strain. Initially completely stable, stayed in home isolation, and when we did a CT scan on the day 1, the CT severity score was just 1, which worsened to 22 on 4th day, and he started desaturating. It was 86% saturation when we admitted and put him to NIV. He was having BMI 39, is an obese fellow, and was also hypertensive, non-diabetic. He went to severe disease, went to ICU, intubated, and in prone position maintained the saturation for quite some time, maybe 8-9 days, but unfortunately developed coagulopathy, the bleeding episodes, multiple complications, multi-organ failure, and succumbed on the 16th day. And many similar stories we have encountered. So we thought that what exactly effect of HIV on COVID-19? So if you ask, could people with HIV have worse outcome? Theoretically it can be yes, because of the low CD4, because of high viral load, because of immunosuppressed state, the risk of ARDS and other viral infections come. However, the immunosuppression is not a clear risk factor for severe COVID, and people with HIV have an increased frequency of some known risk associations, like almost 50% are elderly. They have higher rate of cardiovascular, pulmonary, and COPD and other comorbidities that we know well, and high rates of poverty and marginal housing among the safety net population that we know. Other way around, if you ask, the people with HIV have better outcome with COVID-19, that's also possible. How? Drugs used like the tenofovir, like sofosbuvir, the ribavirin, and remdesivir, they all have effect on the RNA-dependent RNA polymerase, and you know tenofovir inhibits the SARS-CoV replication, is structurally similar to remdesivir. So many thought world over came that does this people treated with tenofovir have a protection against the virus? So there are a lot of trials in the different combinations, including lopinavir ritonavir combination, atazanavir ritonavir combination, and you know that it was proposed that HIV could suppress the inflammation and prevent the associated hyperinflammatory state in severe COVID-19, and as such they are isolated, they are having barrier nursing, so the social distancing is more for them. So early data shows this is two groups. One is the people with HIV and HIV uninfected, and you can see the median length of hospital stay, the ICU admission, invasive ventilation, the myocardial infarctions, pulmonary embolism, DVT and other complications, there is no much difference. It's almost at par, or there is marginal this side, that side, no clear-cut impression from this data. And there are few additional studies which also tells few studies increase mortality and few studies decrease mortality. And the incidence and severity of COVID-19 in persons with HIV receiving ART, and again in this huge one, only 151 were hospitalized, 15 were in ICU and 20 died. And these are the people with HIV, 77,590 were followed who were diagnosed with COVID-19 between February to April 20. This is a publication where HIV did not increase the susceptibility to SARS-CoV-2 and did not increase the outcome of severity of COVID-19, and it was proposed that it can be an effect of ART. And the risk outcome of COVID-19 in persons of HIV receiving ART, it was seen they had a better outcome because tenofovir has had protective effect on those receiving tenofovir were healthier due to propensity to switch patients with comorbidities. And this VSCS, the Veteran Aging Cohort Study, the COVID-19 testing and outcome in people with HIV versus person without HIV showed a clear data that compared in both the groups the HIV uninfected persons with COVID-19 and HIV uninfected persons without COVID-19, they showed almost similar outcome in different tranches, not telling which was adverse and which was good. The routine public sector data, again, the number of people with HIV from 23,308 diagnosed with COVID-19, the standard mortality ratio, death with versus without was only 2.39. That's a clear data. The patients of HIV had 2.39% higher death rate than patients without HIV. So the overall conclusion, taking all these studies, most of the authors did that a picture emerged that there is not much difference in incidence of clinical manifestation of people living with HIV compared to those which do not have HIV infections. So that was the final version if you compare all over the world and similar in our country as well. And NIH also concluded the people with HIV who have COVID-19 have an excellent prognosis and they should be clinically managed the same as persons in the general population with COVID-19. So they told that the people with HIV have an advantage over people without HIV, and because they're already on antivirals and many antivirals have effect on RNA dependent RNA polymerase, this is the conclusion. So finally, before I conclude, the impact, the pandemic's hidden victims, the sick or dying not from the virus, the many social effects like mental health, the substance use, the poverty, the loneliness, the medical mistrust, food insecurity, the housing insecurity, racism, all went. And you will see the susceptibility, the testing, the treatment, the prevention, the socio-economic vulnerability of LGBT, the lesbian, gay, bisexual and transgender, and the communities during COVID-19, they didn't get any attention for a long time. And SS2 HIV testing and the PrEP lowered down, resulting in more patients becoming positive. You can see the graphs, how they have fallen, resulting in more people who were lost to follow-up. And the viral suppression rates and the retention in care also deteriorated because many people had the issues of not getting their consultant, and even in telemedicine 31% did not attend the visits and 30% after the shelter in place order. So the potential cost of interruption of HIV service can be high because the rate from 2008 to 2018, which were almost halved, the AIDS related deaths again can go up because of this poor follow-up, non-viral suppression and increase in the number of patients. So finally, COVID-19 spread in the globally in the high prevalence area of HIV, all Africa, Europe and US. And people with HIV have higher rates of comorbidity, but is tenofovir protective is still a question. And studies to date, the Europe and US have not shown more severe outcomes and increased susceptibility to SARS-CoV-2 with HIV. And one study in South Africa has demonstrated the mortality in people with HIV by a factor of 2.39, which I have showed you. The diabetes and the older age resulted in higher increase in risk mortality. So associated comorbidities were culprit, not HIV. And the main effect of the COVID-19 on HIV will likely be in treatment assess, treatment outcome, testing rate, the PrEP assess, and the susceptibility to HIV. That deteriorated very fast, not the disease, and they have the socio-economic impact now post-COVID time. So the concerns regarding the mental health effects, substance use, food insecurity, housing insecurity among people with HIV all deteriorated. So I thank again for this opportunity, and I'm sure more papers, more studies in this important field will come out and will be wiser in future time. Thank you all.
Thank you, Dr. Jayant. Thank you very much for the elaboration of the various issues. Let us also remember that COVID was not just one disease. Along the waves and different times, we had different types of diseases. But fortunately, for a country like India, I think the ART rollout was reasonably well maintained in spite of various difficulties. So it's a point of discussion that we'll be coming back again and again. Thank you very much. Now let me ask Dr. Ruby to introduce Dr. Neha Gupta.
I think
she's not coming. Okay.
So I think our next speaker will be Dr. Milind, Dr. Major Milind Bhushandi, Nagpur. So I think Dr. Milind does not need any introduction. Dr. Milind is a whole soul HIV in charge of the Nagpur. Okay. And so, sir.
Thank you very much, Ruby. First of all, I thank all the chairpersons, and then Sarji, Sat Shri Akal. So really wonderful gathering, lot of new old faces coming together again freshly. Topic is very difficult, as already been introduced by Dr. Baniyar as well as Dr. Rewari sir. You have made my work very easy. And this late presenting patients, the challenges. So we all know that 95 that we are going to achieve. But everybody is talking about this, and that is the gaps in reaching whether they are HIV positive or not. And these people who are not reaching to test, they are the main late presenters. So we all know there is a success of HIV, early HIV treatment. Everything has been stressed upon by everybody. But at the same time, what we are lacking is, are we looking at the late presenters? So that is the main, because this late presentation is going to have various impacts on the ARV program world over, not in India. Because the data which I am going to show you now, it is all the world over. This late presentation is creating a lot of problems, increase in mortality, morbidity. Specifically, the mortality and morbidity in first 1 year of the late presenters is very high. So by definition, there are various definitions have been given, but the consensus definition is those who are at the time of presentation having CD4 count of less than 350, or they are having either of the AIDS defining illness, WHO stage 3 or stage 4, irrespective of the CD4 count. And there is a new terminology which is coming in, that is LPAD, that is a late presentation with advanced disease where the CD4 count is less than 200. So what are the challenges? The first and foremost, the LPs, that is the late presenters, it's absolutely a diverse condition. We have to have a different strategies because the strategies change as per the countries and the cities and the districts and the villages. The challenges are there to identify and effectively reach this particular population which we are not reaching. Missed opportunity, low self-perceived risk. ये मुझे तो होने वाला नहीं है, HIV तो बाजू वालों को होता है. That is the total, the main reason for not testing. And if they test, there is a fear of becoming positive, and then stigma and discrimination and legal and other regulatory barriers. There is need to comprehensive holistic approach for this. And the last but not the least, that this delay is going to cause the early treatment and subsequently we are going to have problem. Another point which is coming, the series is coming from Finland, where they have said that the low prevalence in the Finland is one of the factors for low late presenters because they are not testing at all. So as far as the consequences are concerned, there are various cohorts right from Africa, Europe and India also, where the population is around 40 to 60% of the patients are late presenters. In India, from the study from AIMS is showing around 83%. So that is the number of late presenters we are having, and the late presenters suffer individual health consequences in terms of high morbidity, mortality. Because of the low CD4 count, if you start them, the chances of IRIS are very high. At the same time, these people are going to have less immunological response, less virological suppression. So you may not get what you require when you start the CD4 count at a high rate. So this is the main problem which you are going to have. And everybody knows the higher the viral load, these people are going to have a lot of problems regarding the cardiovascular, hepatic diseases, renal diseases, and whatnot. So these are main problems with the late presenters. We all know that if you've gone by the hopes, the CD4 less than 50 is one of the attributable risk. It is, if you could talk of tobacco smoking, it is just near about that. So what the UNS have done, they have gone in for fast track. So what is that fast track? 21 million averted deaths, 28 million averted infections, and so on and so forth. But these are going to get absolutely to a very low level if you are not going to have late presenters identification. So this is basically I'm showing this particular data which is from both the studies, combination Cohare as well as Eurosida. It's a huge study, and if you can see the differences between the both, then you're going to realize the percentage of the late presenters. It is there about 48.4% if you total number, and in both the cohorts they have found it out. And what is the result? 39,204 patients were included from the Eurosida as well as Cohare study cohorts, and if you can imagine, the total 48.4% were classified as LP, majority were from West Europe, maximum in a MSM population, and median age was 37, and the majority of LPs had CD4 less than 350. And if you can see that AIDS events as well as the deaths, it is much high in, if you consider the IR into per 1,000 patient follow-up years, then you can just see in all the sectors, right from Austria to all the regions in UK, definitely the LP was associated with 9-fold higher incidence of AIDS or AIDS-related deaths in first year of life, first year of HIV diagnosis. So these are the main challenges which we are facing, and though there is not much very high rate of changes as regarding the morbidity in the long term, but the short term mortality is definitely higher, and it is basically in the older age group who are presenting very late. So the groups at higher risk should be diagnosed and should be targeted for health promotion activities, opportunistic screening, as well as removal of any barriers of testing, and focus on the marginalization population is must. So Indian data from AIMS, they are having, it was from microbiology department, Mindwell, and they have done these particular 4,260 patients, and they have defined LP as less than 200, and if you see the total number 83.4 patients were late presenters in this particular population. So less than 200, it was 39.4, very late presenters were 11.4, and irrespective of the CD4 count, with WHO class 4, class 3, it was 49%. So the results were very alarming from AIMS, and the late presenters remains a significant problem across the world, and we have to have certain specific area-based activities as far as the isolation, the identification of these people are concerned. In my own experience, at my own center, we had total 130 So 172 have come for the first time, naive patients, and after excluding those who are lost to follow-up, 138 patients. This is still going on. So we had around percentage of 80% were late presenters. And the most LPs were male. And Dr. Rewari sir, I will tell you this very important thing, that out of this, 50% were from rural area. And not only that, 23% were from tribal area. And these are the people, because you always talk of what, there is no opportunistic infection much you seen in the metropolis city. But here I am there, sitting in Nagpur, catering for these people, and if you see the amount of these opportunistic infections, apart from Candida TB, we do have PCP, Toxo, TBM, Crypto, and a lot of NAs. And these are all from the rural and tribal areas. And 31 out of 138 had a CD4 count of, that is 22%, and CD4 count of less than 50. And 90 of 135, that is near about 65, had a CD4 count of less than 200, that is the late presenters who are the advanced disease cases. And these are the opportunistic infections. So what are the measures? The first and foremost, if you want to mitigate the LP issue, then you have to have information campaigns, more targeted intervention in the rural and urban areas. We are only focusing on one, that is truckers, MS, the female sex workers, but we are not targeting this tribal area because they don't have knowledge. I will not believe the data is going to come out from this particular cohort where the knowledge of HIV was not there in the tribal area from Yavatmal district and the Dharwad area. So we have to have a very specific thing. The NACO is doing tremendous work. So I'm not having any problem with NACO. But what, as a physician, clinician, the private practitioners are doing, that is what we have to see. There are a lot of opportunities for the doctors in the private sector also, where we can offer the test. That is very, very important, which we are not doing it. And moreover than that, what I see is the provider-associated HIV testing should be much more, rather than we are depending upon the programmatic point of view. So this is very, very important to know these late presenters. Otherwise, your 20, 30, 95, 95, 95 is going for a 6. So if you say that HIV screening is the main thing to improve the survival quality of life and prevent a new HIV infection, then must it is that the HIV screening should be there, which we have to go in very, very vigorous way. So now Dr. Maniyar has already said about this. What he said in his lecture, that this is not the time now, you have to have a routine testing rather than going in for a risk-based testing. So we have already seen that risk-based screening has not been successful. Risk assessment and prevention counseling are resource intensive. The HIV/AIDS epidemic affects all population, and risk-based testing can fail to identify HIV in some patients. And patients do not always disclose or may not be aware of their risk. And that is the reason, if you ask me, I will be definitely going along with Dr. Maniyar sir, that we have to have now a think process. The think tanks should start thinking about the routine one. And this is a very, very important chart which I am showing, though it is late, it is very old one, but you can see where patients underwent testing for HIV. And I was surprised because this is the data from the CDC, which says that sexually transmitted disease clinic didn't offer. So that was the main something, though it is a very 2008 data, but still we had to offer. And what for that we are going to do? Only 17% of the adults who are late presenters say that the physician or healthcare worker has ever suggested on HIV testing. 27% stated that the physician had never recommended testing. 26% of the patients said that they underwent the testing because of their physician recommended it. 25% of the patients assume that it is a part of the routine testing. So in conclusion, as per new data emerging from the various cohorts from Africa, definitely there is a decrease in the late presenters, but at the same time, efforts have to be continued and strengthened to reach the lower, to lower the numbers. In particular, information screening approaches should be targeted, and basically more so in the older age group. Voluntary testing should be encouraged. More comprehensive data at diagnosis would be helpful, and all clinicians should actively participate in early diagnosis. This will definitely result in lower rate of LP and ultimately a better treatment outcomes, as well as reduce HIV transmission, because we all know that task is there, treatment as prevention. So early entry is definitely going to cause decrease in number of new cases. Thank you very much.
Thank you, Dr. Milan.
I have 2 minutes should be given for my next presentation.
I'm not the chairperson for the next one. Okay. Can I call upon Dr. Ravikant Porwal from Jaipur to give a talk on 2 interesting cases?
Good afternoon, everyone. At the outset, I would like to thank Dr. Maniyar sir for giving me this opportunity. The exciting part about practice of HIV medicine is that it gives you an opportunity to revise your entire infectious disease, because you can see many infections even in a single advanced HIV case, which I'm going to share with you. This case we saw in during lockdown times. He is a young male, unmarried and government employee, presented with 2 months history of fever with night sweats and significant weight loss, and there was extreme weakness, fatigue, loss of appetite. There was no significant respiratory and other systemic complaints. So for this he was being evaluated initially in a small remote village where he belonged by a GP, and he was detected to have a HIV infection. So the moment HIV was diagnosed and he was having a prolonged fever, he was empirically put on anti-tubercular treatment, and an antibiotic called Cefixime was also given to him. And as expected, he developed intolerance and hepatotoxicity due to this empiric ATT. So he stopped, and that's where he was referred for further treatment. So when he came to us, he was admitted for evaluation. He was fairly weak, and there was a high-grade fever. There was no oral thrush. There was hepatosplenomegaly, and routine workup showed that he has a significant pancytopenia. Apart from that, other routine workup was okay. His blood cultures was sent as part of prolonged fever protocol. His CD4 was 40 cells. His serum cryptococcal antigen was negative, and as part of HIV PUO, contrast CT imaging chest and abdomen was done, and his CT chest was normal. His CT abdomen showed hepatosplenomegaly and few small size mesenteric and retroperitoneal nodes. So you can appreciate the node size were very small, fairly small. So at this moment, the working DD for us was a stage 4 disease, and probably we are dealing with routine, traditional, common opportunistic infections, TB, lymphoma, possibly histoplasma, HLS. They are all low down in the list. Further, his urine for histoplasma antigen was done, which was negative. His USG guided FNAC, although the size of the node was very small, was done, which was inconclusive. And during his first course of first week of hospitalization, he continued to be febrile, though there was no new organ dysfunction. And this was his CBC counts. He continued to have pancytopenia, required blood transfusions sometime. And thinking of lymphoma, bone marrow aspiration and biopsy was also done. His ferritin and triglyceride was normal, ruling out possibility of secondary HLH. So at this moment, we were not able to figure out what exactly was going on, and we got a call from micro lab on day 5 that his 2 out of 4 blood cultures are growing gram-negative bacilli. So we were definitely not expecting this, and they told that it is Salmonella typhi. So we are really surprised for a fever of 2 months duration in somebody who is fairly advanced HIV. Probably this is definitely not the cause, but since it was a blood culture, bloodstream infection, so we decided to treat with ceftriaxone and cotrimoxazole. And patient said that, okay, now I have a typhoid. It was lockdown times. He did not want to stay in the hospital, so he requested for a discharge and went back. We asked him to come back for a follow-up after 1 week, but he showed up after 2 weeks. And during this time, we took a second opinion on his bone marrow slides regarding his malignancy, and they showed that there is no lymphoma. So he showed up in OP after 2 weeks, and he was still febrile, but the only difference was that now fever was touching to baseline, but he continued to be anorexic, further losing weight, although there was no new appearing symptoms. So at this moment, we definitely knew that only Salmonella typhi was not the cause. His CBC revealed that there was a persistent pancytopenia. So to further work up, TB and lymphoma was still higher on the cards. So we decided to do a PET scan on this gentleman, and it showed that there was mesenteric and retroperitoneal lymph nodes with an abnormally avid FDG uptake, and possibility of lymphoma was high. So with this, we discussed with the family and patient. We did not want to do again a FNAC and sit on the fence. So decided for a diagnostic lab, because it was a little deeper, lymph nodes, transbowel root, etc. was there. So a diagnostic lab was done, and this was the pathology slide, which my pathologist says that there are sheets of macrophages and histiocytes around the vascular area. And there was no granuloma, no necrosis, although the AFB stain was positive. So there was a strong suspicion of atypical mycobacterial infection. We did send his gene expert, which was negative. His AFB culture grew on 3rd week, Mycobacterium chimera, which is a member of MAC family. We decided to treat this. We were really relieved that I think probably this is the cause. We did first line DST on that sample. It was pan sensitive. So at this time, he was receiving MAC treatment with TMP SMX, which would be for his prophylaxis as well as for the previous Salmonella typhi. So he's 2 weeks into this treatment, and he comes back. He's afebrile now, gaining weight, and at this moment we wanted to get him going on ART initiation. But when we did CBC, again there's pancytopenia. And in fact, the hemoglobin really dropped below 5, and he was requiring PRBC transfusion. There was no GI losses at this moment. So we are really confused why this particular thing is not there. And these factors were crossing my mind, that probably he is having HLH or a iris syndrome, whether it is a delayed response, some other OI is also there. So we decided to wait for 1 more week and continued that. So, but 3 days after this, he showed up in OP, and that's where he was complaining of floaters and blurring in his right eye, although there was no pain. At this moment, we thought to take a ophthal exam, whether it is a ethambutol-induced optic neuritis as part of MAC treatment, or something else which we should have thought a little earlier, which we did not think, because there was no hepatitis, there was no other skin lesions, there was no pneumonia. So, and that's where we did a retinogram, and we found that it was classical findings of CMV retinitis. So this was a combination of multiple OIs in a same patient who is fairly advanced HIV. We gave him IV ganciclovir. Because of his pancytopenia, he required multiple granulocyte infusion because there was tolerability issues. He responded very well, fully recovered, vision and cytopenia. And later on, dolutegravir-based ART was initiated, which he tolerated well, and no iris was observed. I think I overshoot time. I have one more case. Do I have a permission to go, sir? Okay, sir. So I'll just run through. He is a 40-year-old male. He is a brick factory owner. He presented with progressive weakness in his legs and unstable gait. And he had recently fallen because of this several times. There was a productive cough which was going on since several weeks. And on detail asking from the family says that he's not really in good shape since last 6 months. He has cognitive changes, personality defect. He kind of prefers to be alone. He has lost significant weight. He was a smoker, consumes alcohol, and one member in his family has been treated for pulmonary TB, but that was decades longer. So on examination, he appeared chronically ill. He coughed frequently, but he was not in respiratory distress. He had fever. Other vital signs were okay. He was inattentive while we were examining him. Neurological examination had paucity of conversation. He was not able to name things about his name, about his family member's name. He has a wide based ataxic gait, and there were diminished strength and deep tendon reflexes, predominantly on the right side. This was his common labs. He has leukocytosis, but normal differentials, anemia. He has HIV positive, and his CD4 was 26 cells. His chest X-ray showed a mediastinal widening. So this was very glaring. So we decided to do MRI as well as CT chest both in his case, and there was a ring enhancing lesion on the right frontal lobe, as well as there was a homogeneous kind of fairly large mass in his anterior mediastinum with with a suspicion of possibly lymph nodal mass. So at this moment we had a newly diagnosed HIV with CNS-SOL and a mediastinal mass with a subacute to chronic in nature. So probably differential was TB, again lymphoma, cryptococcus, very less likely toxo. So with this, we decided to do a biopsy, but when we discussed with the radiologist and they attempted a biopsy, there was a pus came. So there was a involvement of thoracic surgeon and a drainage procedure from the mediastinum was done, and there was a foul smelling pus from around 300 ml. His CSF was also done, which was negative, which was kind of normal. There was HIV RNA around 10,000 copies, and rest of the microbiologic as well as PCR studies in CSF was negative. And this was his gram stain in the pus, which we drained from mediastinal kind of abscess. So this shows that there is a beaded thin filamentous gram positive rods suggestive of nocardia, and the culture also grew nocardia later on. So I think this clearly tells that only in HIV there is a significant immune decline. Even the aggressive bacterial pathology will behave a kind of indolent process until it developed a mediastinal empyema and a brain abscess. So I think that's very, very important to understand. In this particular case, we gave him initially trimethoprim sulfamethoxazole with imipenem. Later on, TMP SMX was continued, and 1 week later, ART was initiated. Thank you, sir. Thank you so much.
Just one question. In the first case, what would you attribute the pancytopenia to?
Pardon, sir?
The pancytopenia would be attributed to?
Because of those multiple AOI, that particular patient had Salmonella bacteremia as well as that Mycobacterium chimera and CMV.
Thank you.
Thank you, sir.
That was very interesting.
Thank you, sir.
We move on to the next case presenter, Dr. Aman Sharma from Chandigarh, a long-term associate of HIV medicine. He will be presenting his case.
At the outset, I would like to thank Dr. Maniar for his very generous introduction and hosting us after a hiatus of COVID over the years. And I'm very happy to present in front of Dr. Rewari, with whom we've learned the ropes through him. Now it's around 16, 17 years of association with Dr. Rewari. I think I'm going to talk about a female who was a challenge for us in PGI. She had undergone surgery some years ago, was detected to have HCV and then HIV, for which a first-line antiretroviral therapy was started long back. There was some, subsequently this was changed. I'll keep it brief. In 2015, when we saw there was irritability, memory loss, reduced self-care, fecal and urinary incontinence, and bilateral positive Babinski sign, and MMSE was 18 on 30. We thought of all these possibilities. We are all aware that we think about these when we are dealing with HIV. We did the CSF analysis. The CD4 had in fact gone up on therapy, and the viral load was just 520, and it was thought that probably it is more likely to be because of blip than truly failure of therapy. The MR which was done, it showed there were diffuse areas of abnormalities, T2 hyperintensities involving various areas. There was no contrast enhancement, there was no midline shift, and the features that the radiologists believe that this is perhaps HIV encephalopathy. And looking at the stage, it probably would have fitted into, since she was nearly vegetative state, herself and the entire family was fairly well educated and from a very high socioeconomic status. They were really pushing us to do something more. We delved deep into this and probably discussed with one of the consultants in the US. This was the viral load in the plasma, which was not very high. But when we did the CSF viral load, it was very, very high. So that is when we thought that perhaps it is a CSF compartment failure. It was not really the HIV encephalopathy. So before writing somebody off that nothing really can be done because the viral loads are normal in the blood, I think make an attempt to do a viral loads in the CSF. That is the final message from my presentation. So patient was started. Actually, at that time, we had, Dr. Rewari would remember that we had not really started third line therapy in the program. And it was on the, we were discussing this with the family, and we proposed this, regime, and she was started on this third line therapy. And there was and to our surprise, there was a dramatic improvement. The patient became near normal. So somebody was was about to be written off at the end of the road, became alive and kicking, and she's still doing very well on follow-up, and I think it's 6 years down the line. And over a period of time, what we did, we've collected 18 patients. Average duration of ART is 9.4 years. The general presentations are in the form of disorientation, cognitive decline, increased forgetfulness, headache, and imaging, by and large, generally shows features of encephalopathy. If you do a CSF, and it might make us believe that the patient might be having some kind of infection. We do all kinds of tests, and I will take this opportunity that whenever, and from this podium, I'll announce that those of you who want the help for any TB work or any NTM work, don't hesitate to ask us. We can practically, my sister happens to be a microbiologist. We can do any test, molecular test, and any advanced test for both TB and for non-tubercle mycobacterium, which can be done at any part of this planet. Having said that, the CSF in these patients did show lymphocytic pleocytosis with elevated proteins. We must be itching to start antitubercular therapies in this patient, but this is probably because of HIV CSF escape phenomena. All patients were on tenofovir and lamivudine combination except two with boosted PIs. These are the pre and post treatment CD4s and the viral loads. You can see there was after therapy there is a statistical improvement. By and large, darunavir therapy with ritonavir and integrase inhibitors have been started in all 18 patients. All had symptomatic improvement initially. HIV viral load became undetectable in 16. And long-term follow-ups alive and on regular follow-up are 16 patients. 1 patient died later on, and 1 has been lost to follow-up during the COVID era. So just quickly touching on what is HIV CSF escape. It's basically replication in the CSF despite a successful suppression of HIV viral load in blood while on antiretroviral therapy. There are 3 different types. One is a blip. This is just akin to the blip that we talk about, just a marginal increase in the viral load sometimes before settling down. This occurs in the CSF also. And we, just like there, we just don't really need to change the therapy. Then there is a slow CSF, slow suppression, CSF viral escape with preceding slow suppression in the plasma, and finally persistent CSF viral escape, more than 2 samples suppressed. So why does it really occur? We are all aware that there is insufficient CNS penetration of the antiretroviral drugs. These are the drugs which have been implicated in various studies, NNRTIs like efferents, some PIs, especially atazanavir, and tenofovir has been implicated with, they have been shown to have less CSF penetration. So HIV-1 infection in CNS becomes increasingly compartmentalized during disease progression. That's what we know. These are the papers, and the carry-home messages are towards your right. Basically, this has been shown to be linked to CNS inflammation and with the use of PIs also. It is hypothesized that we should consider CNS virus escape as differential in all patients with known focal cerebral syndromes who are receiving atazanavir. These are the reported symptoms. As you can see, unusual or bizarre behavior, cognitive impairment, imbalance, seizures, psychomotor retardation, meningoencephalitis, headache, and memory alterations. So, ladies and gentlemen, at my last slide, CSF virus escape must be ruled out in all HIV patients on adherent ART regime with acute or subacute neurological symptoms. Early recognition of this entity is imperative, as neurological dysfunction is reversible and can be very, very gratifying for a physician. Appropriate change of heart regimen at the earliest can completely revert neurological impairment. Thank you very much for your patient hearing, and I will again thank Dr. Maniar for this kind invitation and for his persistence to me that I must make it here despite I was in Ahmedabad yesterday. He was very generous. He asked me to make it, and here I am speaking in front of you. Thank you very much, sir, for the invitation.
Thank you. It was a wonderful presentation. Now we will move to the next speaker, Dr. Naveen Kishoria from Jodhpur. It's over? No, we have the last.
Thank you, Dr. Mania, for the invitation, and I'm thankful to be in this beautiful venue. We have been speaking about, and we have been trying to treat HIV for a very long time with conventional drugs and all, but we fail to see simple clues to a certain pathology, and which ends in drastically different modality which we'd like to have. So with this onset, I'd just like to present a single case, a very small case. Mr. K, age 35 years, a known case of PLH over 5 years, presented to the OPD on 16th of February this year with diarrhea for 7 days, a very common symptom, mild cough for 5 days, nothing very significant, and weakness lasting for 15 to 20 days. He was around 20 days back, he started to feel weak and subsequently started to have a small volume diarrhea, which exacerbated his weakness and had mild cough, non-productive with no fever. There was no abdominal pain, vomiting, associated diarrhea. These loose tails were aggravated with food intake. He also found to have slight headache frontal. On examination, emaciation was present. Obviously, when we tend to see HIV patients, we tend to locate with them or try to identify that emaciation is a part of their plethora. There was no cyanosis, icterus, clubbing, edema, abdomen was soft, bowel sounds were slightly exaggerated, patient was well oriented to time and space in person, no focal neurological symptoms were present. Past history, known case of PLHI from 31/7/15 when his CD4 counts were 384. He was started ART but irregular, dropped to 298. He was lost to follow-up as it happens quite frequently in our zone. He was re-registered on ART on 24/7/21 with CD4 51. He was put on TLD. On 2nd February, his CD4 was 46. On 8th of March 22, it was 70. On 30th 11/2020, he was admitted AIMS Jodhpur with Furniers gangrene and was operated without any major complications at the time. Again, he was admitted for the same on 20th 12/21 and discharged on 2nd of January. All reports at the time were normal. So patient had a common outcome with all these infections and with low CD4 counts and without any major ART treatment going on because he was lost to follow-up initially. Previously, he was admitted at the ID Institute of Medical College with sinusitis, again confirmed by teleendoscopy and with CTPNS and treated conservatively. So he had a normal history. On admission at MDM Hospital, his blood pressure was 90/60, he was feeling weak, his reports were as shown in the box. All were normal except you can see a slightly low hemoglobin 5.4, sodium was low, serum sodium 125, albumin was low, and his stool report was unremarkable. Treatment was started, routine enteritis, patient continued to feel dizzy and lightheaded, and diarrhea responded ultimately to conventional treatment. And since blood sugar was quite low, initially it was repeated and it was around 65 on IV fluids. As you can see, he was anemic and cell counts were depressed. I had to review the history and exam as shown in the insert. A dark pigmentation was found in the buccal mucosa. And as we already know, pigmentation is a part of so many treatment regimens as well as part of CD4, and we can see the review cause of oral pigmentation. A lot of differentials are seen, as we can understand that many endocrinal disorders like diabetes, pregnancy, hypothyroidism, all are associated with pigmentation, and as well as HIV uncontrolled is associated with the buccal pigmentation. And again, a very important review was reviewed. So what happened, we again went back to his basics and tried to ask the question with his wife and all. He said he was a smart guy around 5 or 7 years back. So we had a patient who had poor intake of ART. He had a history of recurrent infection in the form of hernia, gangrene, sinusitis, diarrhea. Also in presentation, lassitude and low blood sugar and low blood pressure with oral mucosal pigmentation. On further research, a comparison made his present looks. As you can see, this is January 2020, on when we saw with this on 2015, his presentation was different. He was looking quite smart at the time. So again, we need to understand this particular point. So considering the generalized pigmentation as a factor, I go for a more detailed investigation. An ultrasound abdomen was done, it was normal. He went for urine sodium estimation, it was 183, it was quite high. Plasma renin activity was 0.2, normal. Cortisol level was 6.3, which was low, 8 AM. Again, a serum ACTH was quite high, as you can see. Now, we can understand ACTH is a pigment, is an endocrine, is a sort of a molecule which actually homologates with MSH, that is melanocyte stimulating hormone. So what is done here is we thought that ACTH is basically the hormone which actually is causing pigmentation. We started thinking on the line of adrenal disease. We did a cosentropin test. A standard dose of 250 microgram of cosentropin was injected IV, and plasma cortisol was done at 60. A normal response is minimum concentration of 18 to 20. As you can see, the patient had no response of ACTH stimulation, high dose ACTH stimulation. So with this, there was also urinary salt wasting. As you can see, sodium also is increasing. So provisional diagnosis of adrenal insufficiency was done, because we'll see how it's important. So this provisional diagnosis of adrenal insufficiency with HIV was done. The cause of adrenal adjacent disease are listed in the insert. As you can see, many infections are cause of adjacent disease. And HIV per se, including HIV treated diseases and the treatment also can cause adrenal insufficiency. And since ACTH was high, we tried to think on the lines of pituitary also, that ACTH was high. So CT, abdomen and MRI pituitary was done. Again, the CT was show normal adrenals, as well as we can see in both the insert also, MRI pituitary was also normal. So just to highlight the point, after going to various reviews, you got a CMV test again done in this particular patient. As we can see in the particular review article, a forgotten diagnosis, adrenal insufficiency, and CMV. So HIV causing adrenal insufficiency was the diagnosis along with CMV as a opportunistic infection was in this patient. So again, the commonest opportunistic etiology in HIV patients with AI is cytomegalovirus. So just to continue in the particular patient, since the patient was having hypotension, IV saline was given, hydrocortisone was started, he was put on oral prednisolone along with fludrocortisone. He was cautioned regarding emergency treatment of infections and use of steroid during crisis. So ART regimen has to be changed according to viral load, CD4 counts, and drug resistance testing. So with this all, we discharged the patient. And just to summarize, just to follow up on that patient, I was very surprised to know the patient died after 1 month of discharge, because the same could not be done at the institute where he was sent. So adrenal insufficiency is a common endocrinological manifestation in patients with HIV. In developed countries, almost half of all the new diagnosed HIV have advanced disease. And furthermore, more than 50% HIV admissions are in base with advanced disease. It may be neglected, but significant contributor to morbidity and mortality in this population. Contributing to this challenge may be difficult with lab diagnosis. And just clinicians need to maintain a high degree of suspicion when managing patients with risk of adrenal insufficiency. This not only will improve timely diagnosis, but also may increase the morbidity and mortality as well. Just to say, war will never cease until babies begin to come into the world with larger cerebrums and smaller adrenal gland. And again, steroids save lives. And you know JFK had adrenal insufficiency and used to take cannabis for that. Thank you.
Thank you. May I call upon Dr. Savita Han Sebastian to give a talk on adverse effects in adolescents.
Good afternoon, everyone. It's an absolute pleasure to be here. I'd like to thank Dr. Maniar for giving me the opportunity to share my 2 cents, and warm greetings to the panel as well, and a special hello to Dr. D.D. Ravindran, my in-house HIV specialist. My topic for today is ARV side effects in adolescents. I supervise the ART center at St. John's in Bangalore. And I'm going to use 2 clinical scenarios in the interest of time and tell you the learning points that I took home. To start off with, case number 1, we have a 19-year-old girl. She was diagnosed at 3 years of age with HIV. She was on tenofovir, lamivudine, and efavirenz, and she's been taking it for over 10 years and was doing really well. In March of 2021, she presented to us with giddiness, headache, lethargy, and low mood. The symptoms were quite vague, to be honest, and we weren't really sure what was going on. On examination, she weighed 38 kilos, and otherwise her systemic examination, including a complete neuro exam, was completely unremarkable. On investigations, we did an MRI brain, which was normal, and her blood work didn't reveal anything. In view of her low mood, we thought it was prudent to do a complete psychiatric evaluation, And that diagnosed a major depressive disorder. We started her on antidepressants, and she started doing a little better. The patient did tell us that prior to the onset of symptoms, she had been started on isoniazid as part of TB preventive therapy. She said her symptoms worsened when this happened, and she stopped it. And she felt that she was doing a lot better once she stopped the isoniazid. She was doing relatively okay, and we didn't really hear from her for the next 9 months. She comes back to us in December of 2021. This time, her symptoms were slurring of speech, difficulty walking, and myalgia. On examination, she had hypotonia, brisk reflexes, and cerebellar signs. So we had a slightly different presentation this time around. At this point, we considered the following differential diagnosis. We thought opportunistic infections in the CNS. However, this seemed unlikely given her normal CD4 counts, a suppressed viral load, and a CSF that was absolutely sterile. We also considered autoimmune encephalopathy. However, her encephalitis panel came back negative. She had pyramidal signs, so we considered myeloneuropathy, but the imaging of the spine and her nerve conduction velocities were normal. Finally, we did consider PMLE, but the MRI brain didn't reveal any white matter involvement. At this point, we did discuss the images with the neuroradiologist, and he did say that he saw a little bit of cerebellar atrophy, and he did ask us to consider a drug-induced etiology. We did a literature search, and of course, this girl was on efavirenz, and we made a diagnosis of efavirenz-induced cerebellar ataxia and encephalopathy. We stopped her efavirenz, and she was transitioned to dolutegravir, and her symptoms resolved within a month. Interestingly, in the adult ward, at the same time, we had an extremely similar case. Again, a 23-year-old lady, cerebellar signs, examination, 28 kilos. I'm highlighting that. I'll tell you why in a minute. And cerebellar signs on examination as well. Clinical diagnosis of cerebellar ataxia. Her investigations, again, completely clean. MRI brain, which is normal, CSF that was normal, blood work that was completely normal, and a viral load that was suppressed. We, in her, again, we made a diagnosis of efavirenz-induced ataxia. We stopped the efavirenz, and within 4 weeks, her symptoms had resolved. We managed to publish this as a case report earlier this year. Now, a little bit about review of literature. Now, why am I talking about this case? So efavirenz, of course, is known to cause a lot of acute and transient neuropsychiatric side effects. They usually resolve over 8 to 12 weeks of starting treatment and doesn't really necessitate discontinuation of the drug. The mechanism of neurotoxicity is not clear, probably mitochondrial toxicity. Late onset efavirenz-induced neurotoxicity has only recently started being described in HIV patients. When we looked at literature, we found 4 studies. There were a total of 31 patients that have been reported to have ataxia because of efavirenz. The last study in particular, I want to point out, exclusively talks about INH precipitating efavirenz toxicity. So the salient points from all these studies were the median duration of drug exposure was 2 years. They were all seen in women, except for 1 case. And all these patients were largely underweight. Now, why does this happen? Efavirenz is metabolized by the cytochrome P450 isoenzyme 2B6. Genetic polymorphisms, particularly a T allele homozygosity in the cytochrome enzyme, results in slow metabolism and supratherapeutic levels of efavirenz. This is reportedly more common in the Indian population. And why does INH precipitate it? INH inhibits metabolism of efavirenz through inhibition of the CYP2A6, which is probably an important alternate pathway in these slow metabolizers. So this makes a case for genetic testing and therapeutic drug monitoring. And we did talk about it earlier in the day. These patients were underweight, and they were probably better off with lower doses of efavirenz. Take-home points from this case: efavirenz can cause ataxia, encephalopathy, and psychomotor slowing. The average time of onset can be 24 months, but it can be as late as 10 years, as was the case in our initial patient. Risk factors are female, patients who are underweight, the T allele homozygosity, and concomitant INH use. With the TB preventive therapy rollout, this is something to bear in mind in patients on efavirenz. The important point is it's reversible. As mentioned earlier, efavirenz, I think, is still a drug that's going to stay around for a while. And it's prudent to keep this in mind so we can pick it up early and prevent morbidity. Quickly moving on to my second case. This is a 17-year-old boy with HIV who was on tenofovir, lamivudine, and efavirenz. As part of the INSTI rollout, the government has rolled out, he was transitioned from efavirenz to dolutegravir in April 2021. Now, there were some LFT monitorings, and I'm just going to display that. His baseline and his 1-month ALT enzymes were normal. Around the 5th month, which is in September, his AST and ALT had risen to 2 to 3 times the upper limit of normal. And by the 6th month, which is November, he had gone up to 5 to 6 times the upper limit of normal, and he also became symptomatic. Investigations to look for a cause included a hepatobiliary scan, which is normal, and acute viral hepatitis markers, which were negative. There was no recent drug intake, and a diagnosis of dolutegravir-induced liver injury was made. We stopped the DTG, and in a week, his symptoms resolved, and in 1 month, his LFT had normalized. Now, we looked up literature to see whether this is something that is reported. So we did the RUCAM score as well to look at the causality to dolutegravir, and he had a score of 4, which indicates possible dolutegravir-induced liver injury. Moving on to the literature review, the Spring 1 trial reported just 1 patient. The Spring 2 trial reported 2 patients with dolutegravir-induced liver injury. The EuroSIDA cohort, which had 2,711 patients on dolutegravir, just had 1 patient with hepatotoxicity requiring discontinuation. In terms of case reports, my literature review revealed 4 cases. One case is important to note, which is of a 28-year-old woman who, within 4 weeks of starting a dolutegravir-based regimen, developed acute liver failure necessitating liver transplantation. So, take-home points from this case. Initial trials suggest that DTG-induced liver injury is extremely rare. However, there have been case reports that say that DTG can cause liver injury ranging from mild liver enzyme elevation to acute liver failure. In all cases except 1, liver injury was reversible. All these cases had abacavir in addition to DTG, so I'm not sure whether it's a combination that's causing the toxicity. Given the large DTG rollout right now, clinicians should remain aware for the risk of hepatitis with these agents, and it would be prudent to monitor the liver function test. The effect of dolutegravir on the liver in our population requires further study. And these are my references, and thank you for your patient listening.
Thank you. Thank you, Dr. Savitha. In fact, to conclude the session that has just been over, it has been a fantastic set of presentations and fantastic revelations. And this points perhaps to what Dr. Milind has stated in the beginning, that there is more need for more exposures, more need for more trainings for junior doctors as well as other physicians and non-HIV physicians. And also, for the attention of Dr. Maniyar, that we need to have more and more conferences like this to discuss such type of presentations. And definitely, there's a scope. The things are not that rosy as we see with ART, and miles to go before we sleep. Thank you.
I thank all the speakers, the chairpersons, and the moderator for the wonderful session we have had. And moving on to the final and the smallest of the sessions for the day. Let me invite on the days Dr. D.G. Saple to moderate the session, who is a very senior dermatologist and who has done pioneering work in HIV and AIDS management for over 32 years. And the chairperson is Dr. Atul Kakar, who is a senior consultant physician from Sir Gangaram, Delhi, and Dr. Vivek Nangia, who is a pulmonologist from Max Hospital, Delhi. Over to you, Dr. Saple, to conduct the proceedings. Just one reminding the small change that we've had. Dr. Jayant Panda from this session has already finished his talk, and instead of him, we have Dr. Neha Gupta from session 3.
Thank you for giving me this opportunity to moderate this session, Dr. Maniyar and his team. Of course, now we are moving a little bit from the clinical to preventive. we have got about 4 speakers. I think, can you introduce first speaker?
So the first speaker is Dr. Major Milan from Nagpur, and he's going to cover the topic of PrEP and PEP. The first speaker.
Yeah, we also invite Dr. Sanjeev Sinha from New Delhi to take the dais, to chair the session.
So he's there.
So the major is back. Now, I thank already Dr. Maniyar sir. Now I thank Dr. Shah and my friend Rahul for fantastic cooperation which they have both of them given to Dr. Maniyar. Sabre sir, namaskar. So now with this I start. This is a very lengthy topic which I am supposed to cover in 7 minutes. I don't know. But what I am going to do is go through this. The prevention of HIV, you have having right from the enhanced HIV testing, treatment as a prevention of parent to child and infant prophylaxis. But today we are going to basically see over the post-exposure prophylaxis and pre-exposure prophylaxis. We all know that we are having fantastic results as far as ART is concerned. So we should have decrease in number of cases. But still the new cases are cropping up. So where we are failing, why we are failing, what are the measures, are they sufficient? And the most important is prevention taking a back seat. Because in US, a lot of people know that the success of ART itself is a contributory factor for increasing the cases, because they are not that much heterosexual sex. They are not much bothered about nowadays about the use of condom in the like that. So it might be one of the factors. So I will not go into the details, but the UNAIDS this year declared the thing as End Equalities and End AIDS, and a very strategy has been coordinated by PCB, which is Global AIDS Strategy. And in this, near about, if you see, 75% of the new infections outside Sub-Saharan Africa are among sex workers, men who are having sex with men, people who inject drugs, transgenders, prisoners. So the strategy has to be now towards these people. So what we can do, in July 2021, the guidelines have been released by WHO. We all know this thing, but the people newly infected definitely are there. Here I am worried about the population, and that population is basically this population. The young people in the age group of 15 to 24, and basically the young women 50 to 24 years of age. So, and this is obvious from the target of 75% reduction 2020, and we don't have much of the adolescent data. With this, I will straightway go in for prevention modalities. It's a combination of biomedical, behavioral, structural intervention so as to reduce the number of new infections. It's a combination, testing, condoms and syringes, microbicides and lubricants, treatment as prevention, PPTCT and PrEP. And a combination of prevention, we know that the TIA projects are there, but for PPTCT, PrEP and PEP and TAS, we are responsible. So I'm starting with PEP now. PEP is what? We are giving PEP to the HIV negative person so as he or she doesn't get the infection. That is very, very important. And this has to be started as early as possible, maximum up to 72 hours. After that is a decision of the physician. But here we should also know that hepatitis B, HBsAg, HBeAg positive, 50% chance of transmission, HBsAg, HBeAg negative 30%, HCV 2%, 0.3% in HIV, it's much less. But we are saying that most of us are being vaccinated with hepatitis B virus, but nobody knows their titers, most of them. So I just ask you to take this opportunity to tell you to do your thing, the titers for hepatitis B. So this is, if you talk of the risk, it is 1 in 333 in needle prick injury. Receptive anal intercourse, it is around 1 in 200 to 6 in 200. And if you talk of the, because these are the patients which are going to come to you. And with flaring up of all the massage parlors, you are going to get all these patients. Like I'm getting a lot of patients nowadays, the data I'm going to share with you, and a lot of questions you have to ask, you have to answer. So as regards the occupational exposure is concerned, this is the thing. I'm not going to the details now because the time is much less. I straightway go in for the, this is what exactly the fact. The data from my side from 2009 to 2016, most of them were the occupational exposure PEPs, and non-exposure PEPs were just 9%. And in last, just 2017 to 19, the non-exposure PEP has increased to 36%. And all the healthcare workers in my series, they were negative. So in post-exposure prophylaxis, we are giving tenofovir, imtristilabine, or lamivudine as a base. Along with that, we should have a third drug, and the third drug which has been told to us is basically a DTG, considering all these factors. So the regime becomes tenofovir, lamivudine along with dolutegravir, which is easily available. Initially it was efavirenz, now it is we have to use dolutegravir, and nevirapine should never be used. Efavirenz only to be used when no option is available. So now going to the most important, and because this is pre-exposure prophylaxis is going to be the next generation practices for you all. And for that, it has to be given to uninfected person with a substantial risk of HIV infection. That is very important. And it is the additional prevention apart from the already existing preventive practices. So this is very important. So what is the substantial HIV acquisition risk? It is defined as HIV incidence greater than 3 per 100 person years, and this is usually seen in MSM, transgender women, heterosexual men and women, and the, who have sexual partners either undiagnosed or untreated with HIV infection. So these are the basically, there are a lot of questions regarding the PrEP, whether it works or not. Yes, definitely it works. Safety profile definitely is there. Drug resistance is definitely low. Hormonal pregnancy, everything is acceptable, but the most important thing is adherence has to be maintained. This was the first trial where there was a definite decrease in the number of incident infections, and from the year 2014-15 it started, and then we had n number of trials which came out. But everywhere, every time we had all these trials, we are definitely they're building up the tempo for starting the pre-exposure prophylaxis. And this is the, you can go on the CCO and you can find out this particular PrEP guidance and how to go about it, who require PrEP. But the important thing is MSM, heterosexual women and men, injected drug users, where you have to document HIV negative test, no signs and symptoms of acute HIV infection, and creatinine clearance should be more than 60. Hepatitis B vaccine, you have to see for the associated hepatitis B. And what we are giving, we are offering them a combination of TDF and FTC, MSM, heterosexual women and men, and the injecting drug users, where creatinine clearance is more than 60. TAF is also now being considered, but there is a lot of problem regarding whether it should be used with the receptive vaginal sex or not. Now, as previously told by the speakers on the LA, that is a long-acting, we do have an injectable intravascular preparation of the cabotegravir, where we are having excellent result. But mind well, before you start the PrEP, for first 7 days for the receptive anal sex and 21 days for the vaginal sex and ID, we have to, they have to achieve this level. And then after every 3 months you have to do this test, and if you will have definitely more than 90% effectiveness. Now the new thing which is coming up is 2+1+1. It is only for the MSM, 2 pills before 2 to 24 hours before the sex, 1 pill after that, and 1 pill after that, 24 hours distance. So this is only for the MSM, and it should not be given in cisgender women and transgender women, as well as transgender men are having vaginal or frontal sex, MSM with the men with having vaginal or anal sex, and people with chronic hepatitis B infection should not be given. So there are a lot of trials. I'm not going to the details.
Milind, 1 minute more. Yeah.
Yes, I'm finishing, sir. So, cabotegravir, yes, definitely we had the efficacy analysis is totally in favor of cabotegravir injectable, but mind well, the missed dose of a cabotegravir is going to create a problem. So, there has to be a very tremendous amount of capacity building, and the TAF versus TDF I have already told you. There are dapivirine vaginal ring, and the uptake in India is very low. As far as the last data which I am having with me, it is less than 5,000. With me, it is just now 7 patients who are on PrEP, who are MSM because I am having a CBO. And here we have to see that there are a lot of barriers. Physicians have to crack those barriers. You have to first yourself get your capacity build up that you can prescribe PrEP, and only then you will be able to tell the beneficiaries. So there are a lot of things, new things have come up. All LA preparations, if you see now, they are only generating going towards the PrEP rather than treatment. Unfortunately, the Islatravir is now in December, they have stopped the trial because of low CD4 count in the treatment. So the take home message is awareness and capacity building is must. PrEP is reality, it's safe, and chances of transmission and resistance are remarkably low. The event driven, that is 2+1+1 only for MSM. PEP, take precautions, non-PEP is increasing. Thank you very much.
Okay, thank you, Milind. And we will go for the next speaker. Next speaker is Dr. Ravi Vadreu.
Good afternoon. I would like to invite Dr. Neha Gupta from New Delhi. She is going to speak on the weight gain, metabolic complication due to currently recommended CART. Dr. Neha, please.
Good afternoon, and I'm going to discuss regarding the weight gain and the metabolic complications of the antiretroviral therapy. So I'll begin with this case. This is a 34-year-old gentleman. In 2016, he was diagnosed with HIV-1 as well as 2, and his hepatitis B and anti-HCV was negative. He has an occasional history of alcohol consumption, and the story goes like this, that initially his CD4 count was 130, and his HIV-1 viral load was 1900, HIV-2 was 100, and he was at this point diagnosed to have tuberculosis, and was also was having cholelithiasis. So he was initiated initially on the rifabutin-based anti-TB therapy, TMP-Asymix, as well as TDF-FTC, as well as lopinavir-ritonavir, because he had a HIV-1 and 2 infection. Then subsequently on this therapy, the patient developed weakness and he had leukopenia. Because of this, the rifabutin was discontinued, and he was also initiated on the quinolone-based therapy. Later on, his CD4 count improved to 354 and the HIV viral load was undetected. But during this process, he developed weight gain and also had some knee pain, which was attributed to the quinolones, which was discontinued. And here the other anti-TB drugs were continued, and he was also continued on TDF-FTC and boosted lopinavir. Now in 2018, he was shifted from boosted lopinavir to raltegravir based regime, as well as at this point we had the TAF which had arrived. So he was on TAF, FTC and raltegravir. And later on he was shifted from raltegravir to the DTG based regime when we had the DTG available because of the cost issues. Now over the period of time he was virologically suppressed. But the issue in this patient was that during the COVID times, he was lost to follow-up, and when he presented to us again, he was found to have increase in the bilirubin, and there was mild alteration of the liver function, and on ultrasound, he was found to have a chronic liver disease with splenomegaly. Also, there was pancytopenia, which was noticed. He subsequently had developed encephalopathy as well. And at this point, he has been on TAF, FTC and DTG based regime. So this is a patient who's living with HIV, who has been on TAF, FTC and DTG, who has developed a chronic liver disease, and this has been touched upon by Dr. Savita as well. So what is false in this patient? HIV directly induces liver disease. HLA-B5701 abacavir hypersensitivity test can be performed in this patient. We can switch to DTG-3TC in this patient or continue with TAF-FTC DTG. So as we all know, there are several mechanisms of liver toxicity or NAFLD, which has become a significant problem in the current scenario. And in fact, with the availability or with the INSTI-based regimes being the predominant regime, the prevalence is going up to 50 to 80%. And the liver effects or the NAFLD can be because of the direct effect of the HIV or also because of certain other co-infections which may be present because of the antiretroviral drugs like the boosted PI, DTG, TAF, and also associated metabolic causes like the diabetes, obesity, and dyslipidemia. In this patient who has developed chronic liver disease, abacavir hypersensitivity test need not be performed because if a patient already has CLD, then abacavir need not be given should not be given in class B and C. If a patient has mild CLD, then it can be given at a reduced dose of 200 milligrams twice daily. In a patient who does not have any liver problem, abacavir is liver safe as such. Now the other, what about continuing with TAF, FTC, DTG or a DTG-3TC? As Dr. Soman was saying that we need to take out every accessory possible. Of course, between these two options, there is a possibility of taking out the staph and continuing only with the dual drug therapy in this patient. And when we talk about the integrase-based regimes and their impact on the liver, DTG has been associated with mild elevation of the liver as per the Spring 2 study, which has been alluded by my previous speaker. The incidence is not much. It is 3% as compared to 2, as well as when we compare it with the RAL, it is 2%. The incidence is not much, but there have been reports of acute liver injury as well. So it is very, very important for us clinicians to monitor the patients on a regular basis with regular liver function test, ultrasound, as well as fibroscan. And NAFLD is going to be a significant problem as well with these regimens. Now coming to another patient who is a 42-year-old lady, and she was on TDF, FTC and boosted atazanavir since 2012. She was complaining of pain in the legs as well as the hands. Her creatinine was fine on investigation. The CD4 was 727 and the viral load was fully suppressed. She was found to have some vitamin deficiency which was corrected, but a BMD test revealed that she has got osteopenia. So in this particular patient who is on the on TDF, FTC and boosted atazanavir, what should be given? TAF 25 milligrams FTC with the boosted PI. Can we shift to ABC 3TC with DTG based regime? What about TDF FTC with DTG or TAF FTC with DTG? So let's discuss this. So when we are definitely, this is a patient, this is TDF related osteopenia, and the options would be either switching to abacavir or using a TAF based regime. When we are using TAF with a boosted PI, the dose is not 25 but 10 milligrams. And with the abacavir, ABC 3TC DTG definitely can be used if the patient has HLA-B5701, the patient is negative for this. This is a particular regime which is associated with less bone mineral side effects as well as lesser nephrotoxicity, but there is some degree of cardiovascular toxicity which has been associated with the abacavir, and one has to again take into account what is the risk factor and can switch to the abacavir based regime in this particular patient who has significant osteopenia. Coming to this TDF FTC, obviously because this is the one which is the causative agent, so this should not be used. And we all know that TAF is definitely associated with lesser nephrotoxicity as well as lesser bone side effects. And this is, as we know that when we are shifting from TDF to TAF, even when the switch is made, there is an improvement in the bone mineral density with the TAF-based regimes, both in the spine and the hip. Now, this is my last case, and I'll quickly go through this. This is a patient who has been on TAF, FTC, DTG. He developed severe weight gain, diabetes, as well as hypertension, and diet and exercise failed. And then he developed this sudden left parietal infarct, and he had this stenosis which required the carotid stenting. So what do we do in this patient who is having these metabolic side effects as well as developing a stroke? So sometimes in clinical practice, we have to take a complete U-turn and probably go back to the regimes which we have been using for a long time. And as I mentioned in my previous lecture as well, that there is a significant weight gain which is seen with the INSTI-based regime as compared to the NNRTIs. They are associated with a lower weight gain. And again, TAF-based regimes are associated with a higher weight gain as compared to the abacavir as well as the other NNRTIs. Coming to the incidence of diabetes, again, it is much more with the INSTI-based regimes as well as more with the PIs. There is close to 25 to 30% higher risk of acquiring diabetes and much lesser with the NNRTI-based regimes. So with this,
2 minutes, Neha.
Yeah.
2 minutes or more.
Yeah. So these are the particular problems which we see with the patients with HIV who have been on the on these drugs. And with this, I think I'll summarize and say that earlier we would say that can we afford to treat HIV, but now the more important question is that can people with HIV live, rather than asking can people with HIV live long, we need to really ask that can people with HIV live a long healthy life, and then regular monitoring is needed to actually help them in leading such a healthy life. Thank you so much.
Okay. Thank you, Neha. It was a good one because metabolic complication is one of the things we have started seeing with the dolutegravir. In fact, about 10% of the people they are putting on weight. And one of the good news, I have done the clinical trial with the bictegravir, shifted to bictegravir those patients who have developed this overweight, and 80% of the patients they could reduce their weight by switching from dolutegravir to bictegravir. It has been accepted by publication. I think it will take a month or two. So I thought I'll share this news. Yeah. Okay, thank you.
So much.
And we'll
thank
go
you so
for
much,
the next speaker. Next speaker, Dr. Ravi. Are you there or no? Okay, Dr. Ravi is going to talk about pre-exposure. Dr. Ravi and me, we are associated since '94. He is from Kakinada, Andhra. Things about Ravi I want to talk. That time he was practicing in a polyclinic. But now what I am proud of him, his hospital is 100-bedded. You just mentioned any investigations about the HIV with the viral testings, with the resistant testing, fungal, any growth, everything is available. That he has reached to that level. So I thought I must mention about it. Ravi, please go ahead.
Yeah. The race between waiting for your return flights and the racing clock there with moderators here. Perhaps I'll take less than 10 minutes. So my job is little made easier by Dr. Milind Brushandi covering on PEP as well as PrEP. So I'll confine myself to my patient data over the last 20 years. So this is the history. Till 1990, when the initial drugs were introduced, there was nothing like a PrEP. It was the first time that PEP was, the term was coined by CDC. Later on, these periodic updates are there, and of course, WHO also gives post-exposure prophylaxis updates along with the guidelines. So this is the definition. So here it doesn't explicitly mention whether it is occupational or non-occupational exposure. But now today, my talk is going to speak only about occupational exposure in my experience. So out of approximately 3.8 lakhs of exposures globally for healthcare workers all over, there are very few seroconversions. This is a very reassuring point. Until 1999, there's only one confirmed case about healthcare worker getting exposed and then getting converted as seropositive. So this already Dr. Brushandi has told us, and only thing is highlighting is that instead of hepatitis B, which is maximal to acquire through healthcare for healthcare workers through professional exposure, HIV is much less chance. That's reassuring. Because this already he has covered. Only thing is where we need not cover a post-exposure prophylaxis, that when the patient is already, the healthcare worker himself is HIV positive, or the patient is negative, or the exposure is only to tears or something, we need not consider. We can just reassure the thing. I'll quickly run through 10 sample case reports. Intern doing a pleural tap, injury with needle which is wide bore, and gloved hands, and source is known PWHA. House surgeon capping the needle after IV injection, needle stick injury, advanced person with HIV, then the doctor is wearing gloves. Phone call frantically, a plastic surgeon doing a surgery in a city about 500 kilometers from me, and at 2 p.m. in a cosmopolitan city in a breast surgery, 16 gauge needle which he is using for a drain directly fell and landed on his dorsum where he is not wearing covered shoes. Frantic call, all his day's surgeries were cancelled. House surgeon capping the needle after IV injection, needle stick injury, advanced patient. Of course, the doctor is wearing gloves. Intern doing a pleural tap. Oh, I'm sorry. Junior doctor, female 22, giving an IV injection, needle stick on bare hands. She was not wearing gloves. Rushes to my chamber, crying, unable to speak. Anxious, cries inconsolably. I had to take 1 hour 15 minutes to just put her in the normal moods. Dermatologist at 9 p.m. on a weekday. Abscess drainage, it's supposed to be a sebaceous cyst which is infected. Needle prick when he was capping. District headquarters he was practicing. No ART drugs were available for him. I had to call somebody in Hyderabad, make the drug available within the next 12 hours in his town. Anxious, very repentant and remorseful. PG doing FNAC for a cervical lymph node, needle stick injury, gloved hands. Source is a fresh case of HIV, not an ART yet. Junior doctor injecting into 3-way cannula, 2 of them trying fresh house surgeons. Source is a positive patient, blood spill on the face on intact skin, fear and apprehension and anxiety, reassured and option of ART given to them. A bizarre case, 5-year-old girl, when she was there with her father, 5 men attacked with knives and big axes and everything. Father is attacked with those weapons. Girl is totally drenched in father's blood, and then attackers left the field. The girl is drenched in blood, and after several hours, the father is found to be positive, and the girl's drenched clothes were left on the body for about 12 hours, like that. Luckily, she remained negative 1 year later. Mother is positive. A healthcare worker who is a filaria field worker came home to draw blood. In spite of the mother's objections, the healthcare worker used the same needle for the child, and the child remained negative after PEP. So we live every day in an unpredictable environment like this. In my clinic, the protocol is immediate access to the doctor or the healthcare worker, to the counselor and to me. No time is wasted. Whatever is the waiting, we'll immediately allow the doctor to come inside. We give them a comfortable place, give them good ambience, reassure them. Preferably I hold them by the hand and I offer them some snacks or cool drinks. Then I'll take a detailed history of the event. With what hand he is holding the syringe, with what hand he is doing what procedure, what is the status of the patient, what is the CD4 data if that is available, and what is the ART status, if there is a viral load data. Most of the times, these are all absent in the data. Baseline test for the healthcare worker, we do not know whether the healthcare worker is already positive. And PEP and contact particulars of the HCW. And we request them again and again to come for a post-test, that is post-PEP test after some months gap, which most of them don't come. We'll have to chase them and do it. This data pertains to about 20 years. Last 4 cases are in 2022. Total records are 118. And the guidelines from time to time with the changing guidelines, they have been followed in giving the appropriate PEP. All are occupational exposures. And if you see, in 2019 and 18, there is a peak of this. Probably the doctors are lulled into kind of apathy and less and less care is taken. That's the reason why I attribute. And time to reporting usually less than 6 hours. The reason may be that every year I'll be taking classes to the junior doctors, postgraduates and the final year medical students about PEP. For half an hour I'll take at the time of World AIDS Day. Perhaps that's the reason there is increasing awareness. And all those in the teaching institute come to my clinic, which is less than 1 kilometer away. And some of them have reported between 6 and 24 hours, rest of them late. And some of those cases where they were reported in my absence in the nights and all, insufficient data. Type of exposure, mostly needle prick, blood and fluid spill in only 1/4 patients. I'll just take 2 minutes more, that's all. And surgical procedures in 8 patients, and others like a human bite or the case I described were 3. 80 people were wearing, that is 2/3 were wearing gloves all the time, and 1/3 were not wearing gloves. Adherence, reasonably good adherence in all my patients. When the published data is seen, only 17% to 20% adherence is there in healthcare workers in taking PEP. Dropouts are due to common side effects like giddiness or gastritis, etc. If there is a dropout, it is usually happening in the first 1 week. And reluctance to get the post-test done. Seroconversion, 0 positives out of the 118. The last 4 are still under observation. Maybe after 3 months, I'll do the thing. The conclusions are, takes time to do a good job of post-exposure prophylaxis counseling. One must be psychologically prepared, all of us here in this room. Most injuries are due to needle capping. Perhaps this is what we need to stress for our nurses and doctors. Record keeping helps in order to share how many are converting really. Yearly updates for interns and doctors will create that kind of awareness. 0 conversions. And these are the references. Thank you very much, Dr. Maniyar and the team. An excellent job after a gap of several years. Thanks very much for the opportunity.
Thank you, Dr. Ravi, for sharing your eye-opening data, literally. I think not many years back only, there was never used to be any policy in the hospital. Luckily, now at least every good hospital at least has a needle stick injury policy now and post-exposure prophylaxis also. Thank you so much. In fact, I am just reminded of a very close friend who had a very similar episode, who road rage kind of a thing, where he had a minor accident with another car, and the driver of the other car came and bit him in his hand. And he wasn't sure whether the blood on his hand and the blood that he saw in the other person's mouth was his or his. So we had to give him the post-exposure prophylaxis then. May I now invite Dr. Aisha Soonawala to give her case presentation on syphilis, the chink in the armor.
So, good afternoon everyone, and thank you to the organizers, especially Dr. Maniyar, for inviting me and accommodating this talk. This is really a very straightforward, unlike the other presentations today, this is going to be nothing out of the ordinary, but something that all of us are seeing more commonly in our practice and facing challenges with. And that is syphilis, which is definitely a chink in the undetectable equals untransmissible armor. So if we go back and look at some of these posters from the Art Deco period in the 1930s and 40s, you can see that there was a huge public health campaign at the time which targeted syphilis and predominantly prostitution at the time, heterosexual contact. You can see this is from the Industrial Revolution period, and this is actually from the Second World War period, which actually says that you can't fight the Axis powers if you have venereal disease. So interesting posters, and really they look like a relic from the past. But none of us can deny that across the globe today, in practically every continent, we are seeing an upsurge in syphilis, in fact a very strong resurgence from everywhere. And multiple studies from across our country as well, this one from North India, another one from Pune, warning us not to let our guard down and showing a significant increase in the past 10 to 20 years, prompting this Times of India article on HIV being on the decline, whereas syphilis cases up. This is CDC data showing us that predominantly syphilis today is among men who have sex with men, almost 40% of cases, men with multiple sexual partners. And interesting to note that as compared to women and men who have sex with women, most of the MSMs who have syphilis have co-infection with HIV. And this study showing a 413% increase in incidence over the past 17 years, prompting the director of the CDC in a press release in 2018 to say, based on this evidence, that we're sliding backward and that systems that deal with sexually transmitted disease are strained to near breaking point today. So what are the contributing factors in men who have sex with men? We know that anal intercourse plays a much higher role with increased vascularization in the area, increased likelihood of tears. HIV risk compensation. Most of these men are on very effective pre-exposure prophylaxis or combination ART. They assume seroadaptive behaviors like sero-sorting and sero-positioning, where they choose partners with similar sero-status and stuff. Virtual sexual networks and dating apps are perhaps the most important reason for a surge in cases today. And one of my homosexual patients actually showing me an app where no matter where he is, on which street of the city he is, on a fingertip he would be able to find multiple partners who are available and willing, and the status of those partners. So clearly a very effective method of increasing the number of partners over here. And then there are recreational drugs like opioids and methamphetamine, which are being used in larger quantities, which lead to disinhibition and impulsive behavior. So with that introduction, moving to this very simple case of this 47-year-old gentleman, Portuguese national, who worked in Mumbai, unmarried, homosexual, multiple sexual partners, who recalls receiving a penicillin shot for primary syphilis at 15 years of age. 2009, he was diagnosed as HIV positive on routine screening, but when he saw me in 2019, he was still ART naive, and perhaps because, as you can see, there was a very slow decline in his CD4 count and an HIV viral load that remained practically suppressed despite not being on any ART. His RPR titers, however, done elsewhere were positive, and that's why he consulted me. He was advised ART even earlier, but he was procrastinating. Looking at his progress, you can say that he's a viremic controller, long-term non-progressor, which are now actually called long-term slow progressors because eventually their CD4s do decline, as had started with this patient. But this gave him a huge boost and he continued to carry on with the same lifestyle. 2019, he developed a painless macular lesion on the penis and he was retreated for syphilis, and that's when he panicked and decided to start antiretroviral treatment as advised with DTG and TAF. You can see the progress thereafter, CD4 remaining more or less the same, HIV undetectable, the viral loads undetectable, and the RPR titer slowly declining. He continues to have the occasional macular lesion on his penis, which spontaneously resolves, and he informs us about it when he comes once in 6 months or a year for a follow-up. No other rash, lymphadenopathy, no constitutional symptoms. He's had excessive weight gain on this DTG-TAF regimen, which we are working on. And he continues to have unprotected sex despite being advised otherwise with multiple partners. Given all these risk factors, of course there's a possibility of reinfections. Yes, he requires regular screening, he requires retreatment, but based on what? Clinical, serological, how often? These are multiple questions that come to mind with so many patients like this who now see us. There aren't any cut and stone guidelines, but here you have a JAMA article, 2016-2018, telling us that an annual test for syphilis, screening for syphilis is recommended for all MSMs as well as HIV positive individuals, and even more regularly, perhaps 3 to 6 months for people who come into the high risk category. Retreatment guidance as per CDC 2021, if an additional follow-up cannot be ensured, or if the initial titer, which was more than 1:32, does not decrease at least 4-fold in 2 years, retreatment is advised with weekly injections over 3 weeks of benzathine penicillin, and treatment failure may actually be the result of unrecognized CNS infections, thereby advising CSF examination, which could be considered as well. This interesting article from CID 2020 shows us that individuals with previous syphilis are more likely to be asymptomatic when they are reinfected. And here you can see in the study on 700 individuals that as the number of syphilis episodes increase, more of them have latent syphilis. Additionally, the adjusted odds ratio of detection of syphilis PCR in either blood or CSF was significantly lower, thus indicating that previous syphilis attenuates clinical and laboratory manifestations of infections with T. pallidum. Another study showing that the immune dysregulation associated with HIV may actually result in slower declines and greater fluctuation in RPR titers than in the uninfected individuals. And this could result in an increased probability of false positive diagnosis of repeat syphilis. So really a clinical conundrum over here. And we know that if we take this lightly and don't do enough about it, there is a vicious cycle and the risk of HIV increases. You can see these men who were infected with any STD in the past 1 year having almost a 3 to 4 times increased risk of acquiring HIV. Multiple mitigation methods have been advised, the most important being repeated risk assessments that we all should pay heed to every time our patients follow up with us, repeated screening, public health role. Perhaps we can take the help of MSM community leaders, industrialists, actors that have come out, social networking sites that could increase awareness, better diagnostic tests, especially for early and recurrent syphilis, point-of-care tests that are now approved by the WHO but not yet available, immunization that there was less interest in but which has sort of come back with a resurgence. We know that there are some vaccine trials in preliminary and preclinical stage and these will need to be followed. This is an interesting Lancet article on post-exposure prophylaxis in MSM patients where they were given a single dose of doxycycline 200 milligrams within 24 hours of sex compared to a control group, and they found an overall relative risk reduction of almost 50% for all STIs, but more than 70% for syphilis alone. Again, important to note here that we don't know what would happen in terms of resistance with this doxycycline single dose, especially for a disease like syphilis where you can't culture the organism and you have no way of knowing about resistance. You don't want to go back to the pre-antibiotic era, and this painting very aptly depicts a man dying of syphilis in that time in the Renaissance era, and he's repelling prostitutes who have come to him, to his chamber. But we really have come a full circle with this, and the current surge has urged the CDC to start a new public health campaign, this time not targeting prostitution, but men who have sex with men. Thank you.
So we have the last speaker for today, which is Dr. Lakshman. He's going to talk about the virological failure, factors and solution.
Very good afternoon, one and all, and thank you, Maniyar sir, for inviting me. I know I am the last man standing between you and the lunch, so I'll just make it very quick. I bring you warm greetings from Apollo Hospital, Navi Mumbai, and my parent institute, Apollo Hospital, Chennai. And what I'm going to discuss is basically a study that we did on first-line virological failure, and we'll discuss what are the findings that we noticed. So friends, what is the need for this study? In India, if you look at the published data on adherence, it has been limited to very few studies, and they usually have used non-standardized adherence measures, different adherence cutoff, and there is paucity of quantitative studies examining the behavioral correlates with adherence. Moreover, in this resource-limited settings, the failure has been defined mainly as clinical and immunological, whereas virological failure has not been defined so much because of the want for doing virological monitoring. So what were our objectives in this particular study was, one, to see what is the incidence of virological failure, what are the factors which are leading to first-line ART failure, looking into the socio-demographic, behavioral, and the clinical risk factors, especially with non-adherence to ART, examine the longitudinal relationship between ART adherence and the presence of virological failure. And for our study, we basically used virological failure as the main determinant, that is measuring the viral load, but we also took into account the clinical and immunological failure as well. So our study flow is something like this. It was a retrospective case control study. The data we collected was from Apollo Hospital, Chennai over the last 10 years. We had around 700 patients, but many of them had missing data. So we enrolled ultimately 310 patients, out of which 100 patients had failed on first-line ART regimen. Again, some missing viral load data was there. So our ultimate group of cases was 80. So 80 patients were there who had failed on first-line ART regimen. And as you can see, the males predominant are the ones who had failed ART regimen as compared to the females. On the second group, when we took as controls, these were around 210 patients who had not failed on first-line ART regimen. So amongst the total 290 patients, 80 patients, that is almost 28% of the patients had cumulatively failed the first-line ART regimen. We also took into account what was the regimen, the social demographics, the CD4 count, the mutation, and the adherence. These parameters were looked both into the case and the control groups. When we defined adherence, we said that adherence and history of treatment interruptions for more than 48 hours were noted, and it was through self-reporting. If any patient had less than 95% adherence, we classified them as suboptimal adherence, and we used the statistical methods like logistic regression, Cox proportion, hazard model to predict ART treatment failure. So what were the results? We noticed that the mean time to failure was around 41 months. That's almost 4 years was the period for time to failure of the first-line treatment. 45% of the patients failed in treatment after being 5 years on treatment, whereas only 4% failed after being on treatment for the first 6 months. So what does this indicate is as the duration of ART increases, the incidence of first-line failure increases as well. Probably it is because of the accumulation of the RAMs. Then when we compare between the cases and the control group with respect to age, sex, whether TB was present or not, and adherence, look at the adherence data. Almost 70% patients in the cases group had suboptimal adherence, whereas only 7% in the control group had suboptimal adherence. So 70% of the patients reported suboptimal adherence and 68% reported treatment interruptions. And we noticed that the poor adherence was significantly associated with virological failure. Look at the odds ratio. The odds ratio is 4. So it shows that in our study, patients who had poor adherence were 4 times more likely to fail as compared to the patients who had good adherence. Moreover, the CD4 count, if it was less than 200 and if the ART duration was more than 3 years, it was again associated with poor adherence and subsequently with the virological failure. We also compared the WHO staging, the initial CD4 count, and the initial viral load between the cases and the control. And what did we find? We found that the patients who are presenting in WHO stage 4 or CDC stage 3 were more likely to have virological failure. Moreover, those patients who had a low CD4 count to begin with, for example, if you see in the cases group, the mean CD4 count was just 116, whereas in the control it was 305. So low CD4 count to begin with, again, were at high risk for virological failure. So what we concluded was the significant risk factors with virological failure were, first, poor adherence, lower baseline CD4 count, WHO stage 4, CDC stage 3, and ART duration for more than 3 years. The question arises, can we predict virological failure? So what we did in an attempt to predict virological failure, we used a statistical method with binary logistic regression model, and we used certain predictor variables like age, sex, duration of ART, association with TB, baseline CD4 count. But it was found that none of these variables could accurately predict virological failure. However, baseline CD4 count turned to be marginally significant, though not statistically significant. So with low CD4 count, we can expect the patient to have virological failure. What were the causes for this poor adherence? So most common were multifactorial, and if we classify the causes included some was due to alcohol abuse, because of financial reasons, pill burden, psychosocial reasons, side effects, and travel distance. But most common was the multifactorial with 2 or more of these reasons. In our studies, patients were more likely to fail or were less likely to fail on newer NRTI with efavirenz-based regimen. That is because probably there was a decrease in the pill burden as compared to the older regimens like zidovudine, stavudine, those things. So newer NRTIs with efavirenz were less pill burden, good adherence, and better non-virological failure. Presence of TB didn't increase the chance of first-line failure in our study. However, in other studies, it has shown that probably presence of TB causes increased pill burden, and so again, there is poor adherence and virological failure. But in our study, we did not find TB to increase the chances of virological failure. However, we also found that irregular follow-up results in poor adherence and contributes to the failure. But friends, we had certain limitations in our study because it was a retrospective case control study, so we could not control some of the possible confounders. Baseline resistance testing was not done, so the exact impact of the primary drug resistance prior to ART initiation and the accumulation of RAMs is unknown. And also, since the current study was cross-sectional in design, it may not reflect the dynamic nature of adherence, which can vary over time. So in conclusion, what we can say is that our study findings demonstrate a strong association between suboptimal adherence, virological failure, and drug resistance amongst the patients who are on first-line ART. We need to develop a better understanding of the structural, interpersonal, culture-specific, regional, and individual barriers to long-term uninterrupted adherence. And our findings emphasize the essential role of viral load monitoring in detecting early virological failure. And finally, in this study, we identified several modifiable behavioral risk factors for ART adherence, such as advanced A-stage disease, low CD4 count, older NRTI regimen, suggesting that the healthcare workers could play a pivotal role in integrating individualized adherence interventions to improve the treatment outcomes. Thank you very much.
Thank you, Dr. Lakshman. It was really wonderful study, and this type of studies are required in future. I think before handing over the organization, we must thank Dr. Maniar for organizing such a wonderful seminar. Yeah. And at the same time, I have some suggestion. Dr. Maniar, during the conference, I think one question should be allowed, because all audience, they come to solve their problem. And one senior person should be allowed to give comment, but limited, not unnecessarily lengthy. These are my suggestions, and many more such functions should be done every yearly, more than going for the big conference. And especially what I like, he has involved all junior people, he has encouraged them, and this is our own data, our country data has been presented. And that's what is very important. And lastly, Dr. Lakshman, I remember Dr. Maniar and myself, we were in Washington in '98, and our friend Dr. Janak Patel is from USA. He said, Dr. Saple, don't bother about CD4. What you require is virus load. CD4 is required if the patient falls sick. Otherwise, you go for the virus load. I remember in '98, he has given us this. Okay, and thank you, my chairperson, and thank you, everybody. You want to say?
No, I thought finally thank Dr. Maniar for an excellent conference. Thank you so much.
I also thank Professor Maniar and everyone from organizing committee for organizing this excellent conference. Thank you very much.
Thank you, our moderator, Dr. Saple, for that wonderful comments, and all the esteemed chairperson. And may I call upon Dr. Keyur Shah from HIV Welfare Society for the final closing remarks. One last thing, who's left the TSAW here?
Just to conclude, whatever begins comes to an end, and I think that's with this CME. We are very much thankful to all the senior colleagues, our friends, for giving their busy time during this busy Sunday. And our special thanks to Natco Pharma. I think without their support, this cannot be possible. I congratulate the team Natco Pharma for their untiring efforts to make this CME successful, and congratulate to them also. And yes, definitely the audiovisual, Mr. Praveen, and whatever the doctors or Dr. Saple suggested and Dr. Sajit Kumar has suggested, we'll be expecting all to see you soon, and we'll be organizing in Congress, HIV Congress in near future, and the dates will be released soon. Thanks. We invite for you lunch. Thanks all.